Ako sa streaming kami. Eh, check. Hello, testing. Check. Hello. Check. Hello. Hello, testing. Check. Hello. Check. Hello.
Hello, good morning.
Good morning, sir.
Programming
Hi,
start.
good morning. Am I audible?
You're clear.
Hello, hello. Trying to listen to you. Yes, I think I can hear you now.
Maybe it is Raju underscore MBK.
వెంకటలక్ష్మి కూడా పంపించాను
Yes.
సర్చ్ చేస్తున్నాను ఇంట్లో ఉందా చూసాను సార్
I did.
Hello.
Hello,
Can you allow me to share? I just want to test it out like yesterday. Good morning, ma'am.
మార్నింగ్ సార్
Yes. Sharing is on.
తర్వాత ముత్తు సార్ కూడా వస్తానన్నారు మురళి
What is seen there?
The title of the presentation, sir.
Okay. Presenter view is not seen, right?
No.
Okay, perfect. And I think, ma'am, you're comfortable, we can do it.
Okay. I think now it's fine, no?
It's fine.
I can just go like this, right?
Yes.
Now it's okay, no? Now you can only see not the presenter view, no, Gautami?
Yes, ma'am. Now
Okay,
just
now,
we can
yeah,
only.
because now I'm working on my laptop, not on my DP, on my desktop.
Okay, ma'am. Okay. Done.
Okay, okay.
think
Then
it's
I think I'll just will stop sharing, and then I think I'll just keep it on so that
Yes, sir. Yes, ma'am. Do that.
yeah, I'll do that. Just stop sharing. Stick to the first slide.
నువ్వు ఈ గ్రూప్ లో పెట్టలేదు లింక్ వాళ్ళేమో నాకు
We can see this PowerPoint slide show. Oh, this show word that you should click on share. After that, whatever you do,
Keep it on
only
the first
the-
slide. Keep it on the. No, this is the last one.
I mean, you can practice it.
No,
So this unmute, no? Please give me.
unmuted.
Then no, you can't.
Yeah, thank you. You're there, no? Yeah, okay.
Okay.
Good morning, ma'am. Video petama. I'll minimize say video control. Good morning, ma'am. Unmute and pit. Please unmute and pit.
Yes, yeah. Now I'm unmuted.
Ma'am,
Good
nice,
morning, Gautami.
nice to see you. I think that is the dean's office.
Yes, that's the dean's office.
Very nice, ma'am. Very, very happy for you.
Thank you very much. I'm just thinking whether I'll be able to join by 9:30 or not when your program starts. It starts at 8:30 or 9:30?
9:30, ma'am. Ma'am, you just 9:40 is the
okay.
inauguration. You just
Okay.
log in.
Good morning, Mala. I'll interfere there. Good morning. Congratulations, Mala.
Thank you so much, madam.
Very happy to see you on the seat. It's my
Yeah.
alma mater.
Yes, yes.
Congratulations. How's the hot seat? I always call it as a hot seat.
It's hot. So you have to take some
Okay. Good seeing you,
scars.
Mala. Yes. Hopefully, I'll try to come and meet you somewhere when I come to Bombay.
Yeah, sure, ma'am. Anytime.
Okay. Okay.
Yeah.
Bye, Mala.
But both of you look very cool on the hot seats also, ma'am.
That will come with experience, Gautami. You will learn it in the future. Don't worry. You're also one of the anticipated ones.
No, ma'am, no, not at all.
You have to experience, many things. Then only you will be able to take it. There are going to be some pitfalls. There are going to be some brickbats. It's going to be there. See, you cannot please everyone, and the rules are in place. So you need to follow them.
Yes, ma'am.
Okay, I log in at 9:30. Yeah,
Ma'am,
Vinay, all the best to you.
Ma'am, thank you. 9:15 you log in and just leave the cell aside. Because if you try logging at 9:30, this platform is only for 100 participants. After that, you might have to log in through YouTube. So please keep it aside because we want you to be there. Okay, ma'am?
Sure. Right.
All the
Yeah.
important
Okay.
parts. Okay. Good morning, ma'am. Varsha,
Thank you.
ma'am.
Good morning, good morning, good morning. I'm on my way to college only. I'll reach another 15 minutes and then I can join.
Okay, ma'am. No worries. You can join by 9:15.
Yeah.
Okay, ma'am.
Okay.
Sir, good morning, sir. Nandakumar, sir.
Good morning, madam.
How are you, sir?
Fine. I'm doing fine. Everything is okay?
Yes, sir. Everything is okay. TK Paul, sir, is about to join, sir.
Okay.
In another 10 minutes, maybe.
Okay, I will listen to that. Okay, no problem.
Yes, sir. He's just coming on a trial run. The program will start by 9:30, sir. But you be on the
Okay.
line because you might not have access if the platform crosses more than 100.
Okay.
You can just log in and keep your phone aside, sir.
Okay. Okay. I told my students also to join.
Okay, sir. Sir, in case they have a problem with logging in because the platform is for 100 and after that they should be seeing in the YouTube. They can log in the seminar hall on the screen and all of them can listen also, sir.
Okay. I'll tell them. I'll tell them. Okay.
Yes, sir. That will not have more of congestion on the platform as well.
Okay.
So how are you doing, sir?
Okay. Fine. ആ സെമിനാർ യൂട്യൂബിൽ കാണാൻ പറ്റുന്നു. യൂട്യൂബിൽ ഒന്നിച്ച് കാണാൻ പറ്റൂലേ? ഇതേ പറ്റത്തുള്ളൂ.
Sir, good morning, Muthu sir. Will you have your presentation once so that we can check? Can you try sharing and checking? Bharat, అక్కడి నుంచి Yes, sir, we can see. Sir, you also need to come online. We can't see you on the screen. Sir, unmute yourselves.
സൂമിൽ കിട്ടും. സൂമിൽ കിട്ടും.
Good morning, Dr. Ruchi. వీడియో ప్లే చేయ అందరూ వచ్చారు కదా అయిపోయాక చెప్పిక
അല്ല സൂമില് ഇപ്പോഴേ കയറിയില്ലെങ്കിലേ 100 പേർക്കേ ഉള്ളൂ സൂമില്. ഇപ്പോഴേ കയറിയില്ലേ അല്ലെങ്കിൽ പോകണം ഇപ്പോഴേ കയറിയാണെങ്കിൽ ട്യൂബിൽ കയറാം അല്ലെന്നുണ്ടെങ്കിൽ
ఆయన చెక్ చేసుకున్నారా ఉన్నారా అక్కడే
వీడియో పర్మిషన్స్ ఆఫ్ చేసుకున్నారు మేడం.
అండ్ ఫోన్ ఏమో స్విచ్ ఆఫ్ వస్తుంది. Yes, sir. Yes, sir. Yes, sir. Good morning, sir.
Good morning, Dr.
Nice to-
T.K. Park from Calcutta.
Yes, sir. Nice to see you, sir.
Yes, sir.
So you are visible, sir. I think you can.
Yeah, I am visible, and you two all are visible to me also.
That's nice, sir.
I'm sorry that my throat is little choked because of
No,
the cough and cold.
no,
Please
sir.
excuse me for the voice.
No, sir. Not at all. It's a pleasure you having as the chief guest for the 8th edition, sir.
Thank you very much.
Even Dr. Nandakumar, sir, was there on the platform, sir. I don't know whether he is on or
Maybe, could be.
Nandakumar. No, Cook, sir.
Good morning, madam.
Morning, sir.
Good morning, madam. Very good morning.
Good morning. Good morning to you.
You just ఇక్కడ రాయాలి వాళ్ళు చూడ ఇందులో రాసిచ్చాను నేను.
ఏమిటి చెయ్యి
మాట్లాడితే వాళ్ళు వినిపిస్తారు వాళ్ళు మ్యూట్ చేసుకున్నాం.
It was nice meeting you at Delhi, sir.
Yeah. This is for the first time I am coming to your program.
Yes, sir.
In spite of the fact that I wanted to join before also, but anyway, I am joining today.
Better late than never, sir.
Yes.
So now we have Nandakumar, sir, also.
Okay. Where is he?
Good morning, T.K. Pal.
Hello.
Hello,
Kumar,
how are
good
you?
morning. After a
How are
long
you?
time, I am seeing you.
Nice to see you after a long time.
Yes. Thank you.
You are still working in that college or?
Oh, I got retired in 2017.
Yeah, I know that.
When I joined JS University. And
Okay.
now working as an emeritus professor there and the director of the research program.
Okay.
I got retired long back, 8 years before.
Oh,
I'm
good.
74 now. How old you are?
Same age.
Yes.
You were always the keynote speakers in various conferences, sir, when we were doing our PG.
Yeah.
And you were very well
Once upon a
appreciated.
time, it used to be.
Yes, sir. Even you were presenting, you were hosting the Kolkata conference, no, sir, in 99.
Yeah. You were there that time?
Yes, sir. I just joined a month ago. A month
Okay.
before that, then,
Okay.
even Nandakumar sir was the first one, I think, to start the PG convention in
We
2000.
had our PG convention just a couple of months before. Were you there in Calcutta PG conference?
Yes, sir. Yes, sir. I was there. The 49th, 24th ISP.
Yeah, that time it was. No, your PG were there in the PG convention here in Calcutta.
Yes, sir. Yes, sir. Recently, they have been attending the PG convention also.
Yeah. How did they like it?
They liked it, sir. They liked it very much.
Okay.
చెప్పు బాగుంది ఇనాగ్రల్ పెట్టు ఇన్వైట్
T.K. Pal, still you are any implant, this thing still going on research or not?
Yeah. I'm in implant research only. I have no scope for the main branch of the Perio things now because I am no way connected to the college.
Ah,
So all the research programs are on implants, and that too is taking place in the JS University.
okay.
My students are the PhD scholars.
Ah,
They are 8 in number nowadays. Two have already passed.
Oh,
The
good.
convocation is awaiting for them. Now it is 6 in number.
You have patented anything that implant?
I am doing research in the cortical implants.
Oh, I see.
Cortico, yeah,
Vertical
yeah.
implant. Okay.
Yeah. What about you? What are you doing now?
I'm in Dean. Actually, I'm working in Dean as a 3 days in a week. I'll go to college, Assisia College.
No, but as per the DCI rule,
Oh,
after the DCI rule, after certain age, you cannot be acting as a dean. You may
no, no.
be the honorary
They are
dean.
given a complimentary.
Yeah. You are not
After,
in DCI role then.
yeah.
Uh,
But we are trying to do some research on this thing, regeneration of the platelets.
oh, very good. You are the fittest person for this program today.
Yeah. That is the topic of today. That's why
Yes.
Gautami
Yes.
asked me. I sent few photos also regarding the regeneration, if possible.
Okay.
Still long way
Uh,
to go.
mhm. Gautami is marvelous. She has been conducting this program for such a long time, for last 7 years.
Yeah, correct. Yeah.
And little praiseworthy.
It's very difficult to sustain that progress.
Ah, really so. I do appreciate her gesture, her capability of getting it done properly. What about that lady who was there in Trivandrum who did her PhD program where I myself was there? I met also you there in Trivandrum.
Who?
One lady who appeared for PhD program. Myself and Dr. Tilled was there. You were there. I met you also there.
Yeah.
I forgot her name.
Prashantila Janam?
Yeah. Good work. What she is doing now?
She is retired also. She is at home only. She is not going anywhere.
But she was young that time.
Eh?
She was very young that time.
But so age is creeping, you know. I think almost 10 years back.
Yeah.
Dr. Verma, you know, Verma has passed away.
Yeah.
Dr. Verma, B.R. Verma.
Yes, I know. How he is now?
No?
Dr. Verma, B.R.R. Verma?
No, he has departed from our soul. 2 years back, she died, passed away.
Oh, acha. Lovely person.
Yeah.
Lovely person.
The old generation, nobody is there now. Everybody is slowly passing off.
Even there, myself is there. Don't worry. Rajuddin is there. Dharkanath is there.
Yeah.
They all are there.
Dwaraganath met, Dwaraganath is in abroad now.
Okay.
Dwaraganath.
Mm.
You're not coming to any idea conferences nowadays.
Yeah, I'm coming.
Tomorrow, day after tomorrow, Mangalore
Yeah,
conference.
yeah. On 6th morning, I'm reaching
Yeah,
Mangaluru.
Bangalore.
Bangalore.
Dilip was there. Dilip is there.
Yeah.
Dilip
Are you
Naik.
coming? Are you coming?
Yeah.
Good.
Yeah.
I shall then meet you there.
Yeah. We'll meet there. Almost time to start now, isn't it? Now, 9:30.
Let them
So
start.
we will, sir, in another couple of minutes, 9:40.
Okay.
We are reminiscing our time, Gautami. We are reminiscing our own time.
Thank you, sir.
Thanks to you for letting us meet on this platform now.
No, sir. Even Nandakumar sir was very active in delivering a lecture in the 3rd edition, sir.
Yeah.
Here to his research.
He's a research person. He's a good-hearted person. He's a great friend of mine also.
Yes, sir. All of you were stalwarts. And now also you are the stalwarts, but then you were in the limelight in the 1990s and 2000s. We always used to look upon you in matters of research, publication, and whatnot. And Vandana ma'am is also there, sir, online. She has come. Good morning, ma'am.
They all are your staff member of the department?
Yes, sir. Let me introduce you quickly. Sir, he is the dean.
Sir, I am Dr. Ramaraj. Namaste, sir.
Namaskar.
Namaste, sir.
Good morning, Team Perio,
Good morning,
Gautami, and the entire team of Vishnu Dental College. Congratulations. Thank you for your, the proceedings. All the best. Hello, sir. Hello, sir. TK Pal, sir. Hello.
Thank you.
Vandana
Good
here.
morning.
Yeah.
Good morning.
Yeah. Good morning, sir.
Good
to
morning.
see you. Yeah.
Sir, this is our team. He is Dr. Anil.
Okay.
She is Dr. Shrutima. She is Dr. Aishwarya. He is Dr. Mohan. He is Dr. Ramesh. He is Dr.
Fine.
Murali.
Thank
And
you.
all of them are very active, and couple of them are missing, sir. They're busy in different program. But it's because of all the teamwork that we are able to do all these sustaining programs.
You are the band master of the whole program. Main person in the whole orchestra.
Inaugural invite.
Yeah. Yeah.
Good morning, Gopal sir. Nice to see you once
Good
again.
morning, ma'am. Good morning. Good to see you too.
Good morning.
And
Good morning,
all the best for the program.
Thank you, sir. The whole of Manipal team is there. Ma'am
Yeah.
from Bangalore and you from Manipal, all the deans.
Yeah.
Today's platform is flooded with deans and vice deans and the stalwarts.
Good
And
morning,
research.
Dr. TK Pal, sir. Dr. Varsha.
Namaskar.
Good morning, Dr. Gopal.
Good morning, madam. Good morning, sir. Good morning, Nandakumar, sir. Good morning. Pal, sir. Good morning.
Good morning.
Good morning, Dr. Srihari. Good morning.
Ma'am, Dr. Mala ma'am has recently taken the chair of the dean. I think all of us.
Congratulations, ma'am, and good morning.
Thank you. Good morning, sir. Thank you very much.
Good morning, Dr.
Namaskar.
Mala.
Good morning.
Good morning, Varsha.
Good morning, Sashi. Nice to see you.
Good morning, madam.
Good morning.
Inauguration. मैडम यूज करने के लिए मिल रहा है ना बस
ऐसे मुझे और कोई इंटरेस्ट नहीं वीडियो ऑन है कैनवस की किया
No, बराबर
Good morning, Bela ma'am. Good morning, Bela ma'am.
Good morning, Bella, ma'am. You're muted.
Unmuted. Fine.
Good morning, Gautami ma'am. Good morning, sir.
Good morning to you.
Morning.
Good morning. Good morning, all.
So I think without much delay, since most of them have joined and the speakers are also waiting, and we don't want this wait to go too long. So let us start. Over to Rihanna.
Very good morning, one and all. On the behalf of Vishnu Dental College, I, Rihanna, postgraduate from the Department of Periodontics, welcome one and all to this 8th edition of Perio Akshaya. Perio Akshaya is a platform for continuous education in periodontics with periodontal forum involving all 3 generations of periodontics across the country. Akshaya, as the meaning implies unlimited, aims to discuss the past, present, and future of periodontics that would enhance and enrich the knowledge on the subject, thereby uplifting the specialty for the betterment of profession. Let us plunge into action and start the program as soon as possible. Let us now begin the most awaited online session, the 8th edition of Perio Akshaya, with the inauguration ceremony. Let us be showered with the blessings of Almighty with the invocation song.
सुखकर्ता दुःखहर्ता वार्ता विघ्नाची दुर्वी पूर्वी प्रेम कृपा जयाची सर्वांगी सुंदर उटिशेंदुराची कंठी झळके माळ मुक्ता फळांची जय देव जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव खचित भरा तुझ गौरी कुमरा चंदनाची उटी कुंकुम केशरा हिरे जडित मुकुट शोभतो बरा रुणझुणती नूपुरे चरणी घागरिया जय देव जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव
Now it's time to invite our most respected, beloved, and dynamic principal of Vishnu Dental College, Dr. A.V. Ramaraju sir, to address this platform. Over to you, sir.
Thank you, Dr. Hannah. Respected chief guest for the day, Professor T.K. Paul sir. Respected senior professors, Dr. Nandakumar sir, Dr. Gopal Krishna sir, Dr. Mala Dikshit madam, Dr. Bela Divedi madam, Dr. Vandana madam, Dr. Srihari sir, Dr. Shashikant, and all other senior faculty who have logged in today. Very good morning to all of you. First of all, I would like to congratulate the Department of Periodontics, Vishnu Dental College, for taking this initiative of organizing this event called as Perio Akshaya. The true knowledge is to be shared, and once it is shared, it will be discussed. Once it is discussed, it will be dissipated. And I think this platform is ideal for this objective of sharing knowledge. Once again, I congratulate the Department of Periodontics, Vishnu Dental College for taking this initiative. Respected Chief Guest, sir, we thank you very much on behalf of Vishnu Dental College for taking your time and having consented to be the guest and with us today. Sir, I would like to quote one experience that in 1995, I was giving my postgraduate exam, Viva.
Yes.
I'm a orthodontist. The last question in the Viva was, can you name some surface modifications of implants? So I was quoting all the things, and finally I quoted your name because you have invented some surface spray on the implants in 1995, if I remember.
Yeah.
So that was the last Viva question I have answered, and I have quoted you in the Viva, sir. So today I am able to see you. Thank you very much.
My pleasure. It's my
all-
honor and pleasure.
Dr. Mala Dikshit, madam, congratulations for being the Dean of prestigious Nair Dental College. Dr. Gopal Krishna, sir, our friend, well-wisher, sir, thank you very much. Sir, Nandakumar, sir, always mentoring the Department of Periodontics at Vishnu Dental College. Thank you very much, sir. And
Thank you.
the madam, everyone, regards from the management to all the senior faculty. And of course, Vandana madam from 1987, madam and sir are our is my teacher, and continuously mentoring both me and Gautami for always being with us and helping us. We are here, we are in this position only because of all the senior faculty who are blessing us always and helping us to progress in our career. With folded hands, I am thanking everyone, all the senior faculty, sir. And of course, today's the main resource persons, Madam Ashita. Thank you very much, Madam, from CODS Mangalore, and Muthukumar, sir, taking this for having consented and to discuss this very important topic of autologous platelet concentrate. And I wish that at the end of today's discussion, everyone in Perio will benefit. Sir, one observation from my end is that among all the dental specialties, whether it is globally, we feel that research in Perio is the highest. It's more than 40%. It's 40%. It's more than 40%, and the other departments do the other research. And one observation again is that Perio has got a lot of scope, not only now having gone into implantology, but I believe that we can get more connected to the medical fraternity, more to what do you say? There's still some disconnect between the medical fraternity and dental, and I believe Perio can take that initiative, sir. You have periodontal pathology, but the general pathologists are not connected. We have periodontal medicine, but the general medicine or of medicine are not connected. So I think some initiative to connect better, because it is the periodontal problem that is causing most of the systemic problems. So there is a huge scope for Perio still further, and with this, all the senior faculty here, Perio, as it is for leading, I wish that the periodontal fraternity will definitely progress further. Before concluding, I would like to thank the moderators, Dr. Varsha and Dr. Srihari, for having accepted this invitation and being with us today. I wish the event all the success. God bless you all.
Thank you, sir. Thank you for your valuable words. Now I take upon the pleasure of inviting Dr. T.K. Paul, sir, Professor and Director of Research, JIS University, Kolkata, who is amongst us to grace this event in person and speak a few words on Perio Akshaya.
Thank you very much. And first of all, I apologize for my short throat. My voice could be a little disturbed, and excuse me for the same. I'm suffering from cough and cold for last couple of days. However, hello everybody. Good morning to you all. It's a great honor and pleasure to be the chief guest of 8th edition of Perio Akshaya. Today, on this platform, we all have gathered to witness a nice program on a debate on platelet concentrates. As you all know, that the nature has given us only one connective tissue which is fluid in nature, and it is known as blood. It easily flows almost all parts of the body and can be easily collected through vein puncture. It has got 3 cell lines, of which platelet is one of them. The small RBCs are very busy with their duty to transport oxygen from lung to all parts of the body, whereas the WBCs are designed to take care of us by their defensive mechanism. The only tiny third cell line is the thrombocytes, which is known as the platelets, are given the responsibility to protect the blood volume from unnecessary blood loss due to trauma or otherwise. The platelets are the representative of a big boss, which is situated in the RE system in the bone marrow. Basically, it can also be produced by lung tissues. Nowadays, it is revealed that else some other parts are also there, where from the platelets are being generated. But mainly, over 95%, they are generated in the bone marrow. And they cannot pass through the small sinusoidal spaces in RE system. Instead, protrude their cytoplasm into the blood circulations. Amazing. It cannot come. In contrast to the RBCs and WBCs, they only send their cytoplasmic remnants, which is known as the cytoplasmic extensions, which are shed off from the mother body of the megakaryocytes and separated from main cell. While separating from the main cytoplasm, they usually take 5 to 7 mitochondria, messenger RNA, and also some other chemicals back from the mother. With those materials, they take the journey in the bloodstream for a period of 1 week to 10 days. Unlike RBCs, who can stay for 120 days, and WBC maybe for 15 to 20 days. Each day, the megakaryocyte can give rise to 2,000 to 5,000 of such platelets formation from each protrusion, and a totaling of 1:10 to the power 11 platelets a day. The huge number of platelets are being generated. This is a huge task a megakaryocyte does. The granules of cytoplasm of platelet contain the blood clotting agents, numerous other chemicals which are important in giving signals to neighboring cells to divide, to migrate, to bring closer to the own spaces for filling the gap. The PRP and the PRF both are experts in doing so, but PRF seems to be more efficient to perform their own duty. The periodontal surgical wound is very small, and the regeneration of this small area of defect is very difficult. This task of building up the lost periodontal structure can better be reconstituted of such magic autologous PRP is giving inside the defect after proper preparations of the recipient bed. It can invite undifferentiated mesenchymal cells present at the apically located area to coronal directions to come easily and close the gap. The second generation product PRF is much better to handle over such a Herculean task and can also be incorporated with the different bone graft substitute biomaterials. The choice always lies with the operator. One question comes in my mind, please think on that also. Nowadays, all the cardiac patients are almost on the antiplatelet therapy. Since PRF is separated from the prepared without addition of anticoagulant in the laboratory or even in the clinic, do we need to prepare the patients adequately by 7 to 10 days of the drug intake? Research in this direction should take place. So that is what I think, that the time has come to do little research on that. The patients suffering from different hypertension or cardiac diseases, they are with the antiplatelet therapy, whether the antiplatelet therapy comes in the way in preparing the PRF or not. And thank you very much. Thank you.
Thank you, sir. Our pride and dignity is our national anthem. Therefore, I request everyone to stand up for the national anthem.
Okay.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all the dignitaries the occasion to making it as special as it can be.
So once again, a good morning to all the participants on the Zoom platform. I think without much delay, we'll be starting by sharp 10 o'clock. And a small note, as we have close to 300 registrations, but this platform is open only for 100 participants. The rest of the participants can get the best of the session on the YouTube link provided in the group of the registered participants. But the certificate will be given to everyone. That's not a problem. So after 10, the platform will be closed. But you will have the choice of listening to the presentations on the YouTube link. And the link was already sent to you in the group that was created for all the registrants. Hope you understand. So without much wasting of time, let's go on with the session. And the introduction to autologous platelets will be led by none other than Dr. Ashita Uppur ma'am, who is the Dean of MCOS Mangalore. It will be introduced by Dr. Varsha Rathod ma'am. Over to you, ma'am.
Good morning, everyone. Good morning, esteemed dignitaries. And without much ado, even I would not name each one of you, but the due respect is always in my heart. And I feel honored and privileged that the Vishnu Dental College and my dear friend and a very aspiring Dr. Gautami, I know she is going to reach mountains. She is going to do very well. Thank you, the organizing committee, for appointing me as the moderator. And I take the privilege of introducing Dr. Ashita Uppur madam, who is very dear to me and to all of us. So madam has graduated from prestigious Nair Hospital Dental College in the year 1988, BBS, and her MDS is from Manipal College of Dental Sciences, Manipal, in the year 1994. Presently, she is holding the esteemed post of Dean and Professor at Manipal College of Dental Sciences in Bangalore. She has presented several scientific papers and guest lectures in various national scientific forums. She is also a reviewer of reputed dental journals of our fraternity. She has conducted clinical trials for industry-based research. This is a very good applauding point for madam. She is editor-in-chief for Journal of Interdisciplinary Dentistry. She has also authored the textbook of periodontology and implantology for Elsevier publishers, which we all know in the as an adaptation author of Southeast Asian edition of Karanja's Clinical Periodontology. So over to Dr. Ashita Uppur madam for her insights in today's topic, autologous platelet concentrates in periodontics, whether it is an evidence or an enthusiasm. Thank you.
Thank you, ma'am. Ma'am, you can share your screen. You can unmute and share your screen, ma'am.
Okay, this Can you see the slide?
Yes, ma'am, we can see the slide.
Yes, yes, madam.
1 minute. Huh? Is it visible now?
Yes, ma'am, it's visible.
Okay. Thank you, Dr. Gautami, for giving me an opportunity for this topic, which is very close to my heart. I think before further ado, I'll just directly go into the introduction of this platelet concentrates. Now, as we are all aware, that platelet concentrates have emerged as a widely utilized therapeutic option in clinical settings. Now, they were created and developed to make human blood proteins as a source of growth factors, capable of inducing angiogenesis and tissue ingrowth, which is based on the notion that tissue will regenerate and will need a blood supply to regenerate. Hence, it is widely popular in various health disciplines, including orthopedics, dermatology, and dentistry. Now, coming to the use of platelet concentrates in dentistry, now they were specifically the PRP and later the PRF, they gained significant popularity in dentistry somewhere in the late 90s, and it is growing rapidly through 2000, and now, in fact, it is very popular since 2010. These autologous blood concentrates were adopted to accelerate tissue repair and improve bone regeneration in oral surgery, periodontal, and implant dentistry. Now, since it is the most cost-effective method, it has gained popularity in dentistry. Now, when we take a look at the evolution of these platelet concentrates, they have come a long way. Each introduced to overcome the limitations of its predecessor. Now, in the late 90s, which was the start, PRP was introduced into dentistry for oral and maxillofacial surgery to improve bone regeneration in mandibular reconstructions. Now, the first generation of these preparations were relatively complex, which included the use of anticoagulants and coagulation factors. Then in the early 2000s, we had the second generation of platelet concentrate, which was PRP. Now, what happened is the addition of bovine thrombin, which was causing allergic reactions in patients, led to Chokran, who developed PRF in France in 2001. And thus, it gained popularity throughout the 2000s as it was easier to prepare, 100% autologous, and did not require anticoagulants. Now, 2010 and beyond, we had the use of advanced PRF preparations such as advanced PRF, injectable PRF, which became popular for soft tissue healing, extraction socket preservation, periodontal defects, and orofacial harmonization. Recently, the fourth generation, wherein the current research focuses on integrating stem cell therapy in PRF. Now, enthusiasm for platelet concentrates stem from the ability to jumpstart the body's natural healing cascade. Developed as a revolutionary biofuel for healing, these blood-derived materials gain popularity because they act as a concentrated source of autologous growth factors and fibrin, offering a very safe, low-cost, and efficient way to accelerate tissue repair and regeneration in both hard and soft tissues. Now, since the introduction of PRF in 2000, PRF and its derivatives have evolved as a cornerstone of periodontal therapy with broad applications across non-surgical therapy, intrabony defects, furcation management, and perioplastic surgery, with multiple studies employing them. Now, why is PRF considered the rising star in periodontal therapy? It delivers a sustained release of critical growth factors like PDGF, TGF-beta1, IGF, and VEGF over 7 to 14 days, while its dense fibrin scaffold provides perfect biological matrix for cell migration, angiogenesis, and rapid soft tissue regeneration. Another major advantage is that it offers patient-centric outcomes, less invasive, lower morbidity treatment with satisfactory aesthetic outcomes, making it highly attractive. Now, studies on platelet-rich fibrin are being published on an almost daily basis in periodontics, demonstrating its effectiveness as an autologous scaffold-rich material that enhances both soft and hard tissue regeneration, accelerating wound healing, and reducing post-operative pain. It also claims to be an alternative for connective tissue graft. Conversely, there are several randomized clinical trials which report that they provide no significant added benefit when used alongside bone grafts or guided tissue regeneration. Robust systematic reviews and meta-analysis often show inconsistent, weak, or no statistically significant benefits over controlled treatments such as OFD alone or standard guided tissue regeneration with regards to long-term clinical attachment level gain, or in some cases pocket depth reduction despite high short-term wound healing potential. In addition, Recent meta-analysis and SRs consistently show that while PRF is effective for wound healing, it is generally not a complete clinical equivalent to the connective tissue graft. Now, platelet concentrates once hailed a breakthrough, it now occupies a gray zone in modern medicine. Despite a strong biological rationale for aiding healing, clinical evidence is inconsistent, methodologies are not standardized, and the hype often outpaces high-level scientific proof. With this field evolving at an exponential rate, it is crucial for us to separate the science from speculation. In today's growing need for evidence-based dental practice, bridging the gap between research and clinical application is important. Now, the critical question arises: is the use of platelet concentrates in periodontal therapy evidence-based, or does the wide employment stem from the ease of availability and preparation? Now, despite growing enthusiasm for them, it's important to analyze if it is evidence-based promise or premature hype. Are they truly worth the hype? If it is, why are there mixed clinical outcomes? Where is the lacuna in the literature? Several high-quality systematic reviews have challenged its clinical relevance, suggesting that its benefits may be overstated. Most included studies on PRF had methodological flaws and inconsistent results, with several failing to demonstrate any significant clinical improvement. Now, this uncertainty stems from its rapid clinical adoption without robust preclinical validation and poor standardized protocols. Unlike factory-made drugs, they were introduced directly into clinical use without step-by-step testing in animals or cell models. Now, where is the evidence buried under the overwhelming enthusiasm? And I think one of the major limitations of all the studies was lack of standardization. Now, the development of automatic preparation was expected to contribute to standardization of preparation protocol. However, it did not produce quality preparation. The preparation method varied a lot in terms of different centrifugation speeds, times, types of tubes, anticoagulants, activators, and with no universal protocol, there is a high rate of heterogeneity reported in the studies, making the results difficult to compare. Another issue is the fundamental biological questions which still remain unanswered. What is the precise mechanism of action? Well, while it is known that platelet concentrates are a beehive of growth factors that promote angiogenesis and cell proliferation, the complex interaction between platelets, leukocytes, and the fibrin matrix in different tissue environments is still not fully mapped. Current evidence mainly comes from in vitro studies. However, these in vitro studies fail to translate into in vivo effectiveness due to rapid degradation of PRF matrices in the body and the absence of natural enzymatic breakdown in lab settings. The other question that still remains unanswered is, are erythrocytes actually beneficial in healing? Is platelet activation necessary before, or does it happen naturally in the tissue? And the role of leukocytes still remain debatable. Do they worsen inflammation, or do they favor in post-operative healing? I think this is something which I think Dr. T.K. Pal sir talked about. Now, there's a still lacuna in the understanding of how patient systemic health can affect the active ingredients in these platelet concentrates. The systemic health of a patient plays a significant, often critical role in its efficacy as they're derived from the patient's own blood. Therefore, the concentration of platelets, growth factors, and leukocytes is directly influenced by the patient's overall health status. Systemic factors influencing them include chronic disease and comorbidities, smoking status, medication, then the effect of age, the baseline nutritional, and the blood status. Now, I think these are certain open-end questions. Now, I leave it to Dr. Gautami to talk about the evidence of platelet concentrates. Before that, I would like to just introduce Dr. Gautami. Now, Dr. Gautami, I think it's a very proud moment for Gautami to have her guide, Dr. K.L. Vandana. In fact, she completed her MDS in 2001 from College of Dental Sciences and from Davangere. Since then, she has been totally into academics since the last 25 years, striving for academic excellence in the field of periodontics with the unique initiatives like Perio Akshaya, Vishnu Adyan, Vishnu Akanksha, Vishnu Anveshan, and Perio Inspiron, and Perio Anveshan. He's also an active member of Vishnu Implant Academy, having delivered various lectures in both periodontics and implantology. She is also actively involved in research with innumerable publications in the field of periodontics. She's also a reviewer for various journals in periodontics and implantology. And at present, she's working as a professor and head of the Department of Periodontology at Vishnu Dental College, Bhimavaram. Over to you, Dr. Gautami, to speak on evidence of platelet concentrates in periodontal therapy. Thank you.
Warm greetings from Vishnu Dental College. And it's a proud moment for me to once again host the 8th edition of Perio Akshaya successively. And with the introduction of the topic autologous platelet concentrates in periodontics by Ashita Upur ma'am, I will be dealing with the evidence related to platelets today, or the platelet concentrates. And now coming to the topic per se, that is autologous platelet concentrates in periodontics. The evidence part, over the past 2 decades, periodontology has witnessed a paradigm shift from conventional repair-based approaches towards a biologically driven regeneration. At the heart of this transition lies an increasing emphasis on harnessing the body's healing potential, and these platelet concentrates have emerged as a promising adjunct in periodontal therapy, offering a biologically active reservoir of growth factors, cytokines, and fibrin matrices that can modulate wound healing and tissue regeneration as well. However, despite their growing clinical popularity, the scientific literature presents heterogeneous findings, raising critical questions regarding their true regenerative potential, optimal protocols, and predictability of outcomes. This underscores the need for a clear evidence-based appraisal of autologous platelet concentrates in periodontics, and one that distinguishes biological plausibility from clinical reality. And this session of mine today aims to critically examine the current evidence on autologous platelet concentrates in periodontal therapy, explaining and exploring their mechanisms of action, clinical indications, limitations, and future directions, thereby guiding clinicians towards informed and judicious use in contemporary clinical practice. And what are autologous platelet concentrates? As the definition goes, these include a group of products that are prepared from own autologous blood of the patient, which are intended to enhance the bone regeneration by triggering the natural healing response. And what is the rationale behind platelet concentrates? A major objective of biomaterial research and tissue engineering in today's scenario is to promote a material-induced tissue regeneration that leads to regeneration and an effective wound healing process in the defective area. And in this sense, healing is a complex organization mechanism or a process involving cellular organization, chemical signaling, and the extracellular matrix for tissue repair. And the understanding of healing process is still incomplete, but it is well known that platelets play a very, very important role in healing. And answering to Ashita ma'am's question, do leukocytes really help or worsen inflammation? They have definitely a dual role to play. In the early phase, they act as antimicrobial defenses, thereby resulting in cytokine signaling and angiogenesis. Whereas when they're excessive or uncontrolled, it leads to prolonged inflammation. And then coming to the fundamental biology of how do APCs work. I'm not going to sit and explain in detail the biological mechanisms, but I want to talk more on the evidence of the work that has been published in this short period of time. So the fundamental biology between how the APCs work is by providing a scaffold, the releasing of the growth factors, especially the VEGF, PDGF, and TGF-beta, and recruiting fibroblasts, endothelial cells, and osteoblasts, thereby modulating inflammation via leukocytes and cytokines. And what do platelets have to do healing? As of now, the healing process and its understanding is still incomplete, but it's well known that platelets do play a very, very important role in homeostasis and wound healing. And as these platelets contain PDGF, TGF-beta, VEGF, and IGF, each having a specific mechanism of their own, they release multiple growth factors and bioactive proteins that are directly involved in wound healing and tissue regeneration. And these growth factors stimulate or help stimulate the fibroblasts, osteoblasts, endothelial cells, and periodontal progenitor cells, contributing to soft tissue healing, bone regeneration, and attachment gain, which are all the key goals to successful periodontal therapy. And the platelets regenerative potential was introduced way back in 1970s when most of us were not born. But then when it was observed that they contain growth factors that are responsible definitely for increased collagen production, cell mitosis, and blood vessels in growth. And as I've been explaining the previous slides, many factors such as fibrinogen, and factors, and fibronectin can be released from platelets to form a clot to control bleeding and stabilize the wound. And thus these components may contribute to enhance attachment of PDL cells. And in addition, all these growth factors were found to stimulate cell migration even. And these are the key articles in the evolution of platelet concentrates. And many a times the question arises, why so many generations of platelets? But then each generation was developed to overcome the limitations of the previous ones, which I'll be discussing. And coming to the first platelet concentrate, that's the platelet-rich plasma, which was first introduced by Whitman in the year 1997 in oral surgery, thereby reporting that it enhances osteoprogenitor cells in the host bone and bone graft. But then its use was limited and almost it's become a it's not in existence anymore because of its bovine thrombin generating antibodies to factors 5, 11, and thrombin that could enhance coagulopathies, which might endanger life. And these are various PRFs and the centrifugation protocols. I just don't want to go into details of all this, but these are the most common PRFs that are available in the literature and which we use on a clinical basis. And then coming to the PRF, the man behind the PRF, who was Dr. Joseph Chokran, who developed it, and stating that it acts as a biodegradable scaffold, favoring the development of microvascularization and able to guide the epithelial cell migration to its surface. And also PRF serves as a vehicle in carrying cells involved, and it also has a complex architecture of strong fibril matrix with favorable mechanical properties and slowly remodeled similar to blood clot. And all of us are aware of the advantages of PRF over blood clot. Why PRF? Definitely PRF is more homogeneous and stable, thereby making it for us very easy to handle and placing into the desired sites most of the times when we are trying to regenerate a defect. And these are all the studies that have evidence demonstrating PRF as a healing biomaterial or a healing or a bone graft aiding its role in various regenerations and reattachments. These are the classic studies that have been, and most of the studies in PRF have been published after 2000. And I just want to put the evidence of the literature studies that have been there so far. And this is an in vitro study demonstrated great potential to cell attachment and a stimulation to proliferate and differentiate osteoblasts. And this study by Dohan Ernest, which is the landmark study, stating it as a material that can definitely have a potential to cell attachment and stimulation to periodontal osteoblasts. And studies that stated PRF has immunological and antibacterial properties as well. And a study which stated that PRF could serve as a resorbable membrane for GBR, thereby preventing the migration of non-desirable cells into the defect and providing a space that allows the immigration of osteogenic and angiogenic cells, thereby permitting the underlying blood clot to mineralize. And this study by Molly in the year 2006, which was a retrospective clinical comparison of jaw bone augmentation, stated that autologous bone grafts remain the gold standard, and while titanium membrane can be used only as an alternative. And the concept of natural bone regeneration by Sinopiri, who mentioned that regeneration through PRF membranes result in both the volume and gingival tissue enhancement. And in this study, the authors reported statistically clinical results related to reshaping of the whole alveolar bone and the restoration of gingival form and peri-implant form, thereby achieving adequate mechanical and aesthetic properties. And this study on PRF has exhibited favorable clinical results in the treatment of periodontal infrabony defects, thereby stating that PRF is a beneficial biomaterial for periodontal regeneration, supporting fibroblastic activity and tissue repair in infrabony defects. And there are innumerable studies stating that protecting open wounds from oral environment when the suture cannot bind the mucosal margins. And these are the list of authors who have done various studies on the use of PRF to protect the oral environment as a bandage. And there are even studies accelerating hard and soft tissue healing, wherein again Chokran et al. And Simporelli, they have given a review of PRF applications demonstrating faster wound healing, reduced inflammation, and enhanced soft tissue regeneration. And also the bone graft integration was enhanced in studies with PRF, thereby improving the implant stability and soft tissue healing compared to PRP. And clinical studies that used PRF membrane as a sole grafting material to achieve maxillary sinus floor augmentation, presenting promising results. And even authors, including Toffler, recommended the use of PRF membrane to seal an undetected sinus membrane perforation during a lateral window osteotomy in an axillary sinus lift procedure, which is one of the most common complications that we are encountered with. And in that case, PRF promoted successful bone formation and implant integration within 6 months, thereby stating that it's a viable alternative to traditional bone grafts for sinus augmentation procedures. And there are even studies showing that PRF membrane helps in wound healing, protecting the surgical site, promoting soft tissue repair. And PRF acting as a biological connector, which attracts stem cells, favoring the migration of osteoprogenitor cells to the center of the graft and thereby providing neo and angiogenesis. And this study by Ilmaz in 2014, which was a histological study, and when PRF combined with beta TCP improved bone formation compared to beta TCP alone. And the authors concluded that PRF enhances the osteogenic potential of beta TCP, making it a promising combination for bone regeneration. And even Chokran et al. Study, in this study, the results showed a decreased healing time prior to implant placement, and also the addition of PRF to the bone graft can lead to the reduction of bone volume substitute used and seems to improve revascularization, thereby supporting neoangiogenesis. And again, a study by Simon Perry suggested that using a mix of PRF with bone graft placing in bone defects or in cases of immediate implants covering it with several PRF layers, noted very good clinical results, thereby telling that it's a superior alternative definitely to PRP, which is no longer used, and thereby enhancing bone graft integration, implant stability, and soft tissue healing compared to PRPs. And this is one of the hot topics of a periodontist. Does really PRF work in an intrabony defect treatment? There are definitely studies stating that CAL increase was statistically significant in the test groups wherein PRF was used compared to the control groups. And this interesting experiment by Zoe, wherein he compared the effectiveness of 4 biomaterials like PRF, PRP, EMDs, and amnion membranes in combination with DFDBA, and it was shown that all subgroups that used PRF and PRPs showed statistically significant differences compared to DFDBA alone. And these studies suggest that regeneration with autologous platelet concentrates is definitely more effective than using graft materials alone, wherein they act just as an osteoconductive scaffold. And these are the recent studies in the last 10 years which have stated that PRF can stimulate the proliferation of PDL cells, thereby giving us a promise that PRF-based scaffolds are definitely effective for and these are studies depicting the polypeptide growth factors to have an important role in the growth and differentiation of cells that are involved in periodontal wound healing. And CGF improved bone regeneration periodontal healing compared to conventional treatments, thereby PRGF and PRF stating as an effective biomaterials for promoting gingival healing and tissue regenerations. And these are the various studies that have shown that the use of autologous platelets is a convenient method that can help to concentrate not only PDGF growth factor, but also epithelial growth factors, vascular endothelial growth factors, insulin-like growth factors, and basic fibroblast growth factors. And these are all the studies that have been conducted in less than a decade. And these are the studies depicting other growth factors, including in PRF, such as fibroblast, epidermal, thereby which have shown promising results in stimulating PDL cell proliferations. And then coming to the LPRF, which is second generation PRF, which was again developed for tissue healing and regeneration. And its applications in periodontology and oral and maxillofacial surgery have been extensively documented in the literature. And the advantages of this LPRF are its biocompatible, autologous, cost-effective, and sustained growth of factor release compared to the conventional PRF. And this was a study in which the microbial properties of LPRF and PRP were analyzed, and LPRF definitely exhibited strong antimicrobial activity, reducing bacterial contamination in surgical sites. And these are the various studies in the literature that have stated, that have compared LPRFs and PRFs in general, showing better, superior results compared to products alone. And then coming to titanium prepared platelet-rich fibrin, wherein this platelet concentrate uses titanium tubes to activate platelets, and which was developed by Mustafa Tunali. And this TPRF has come into existence to avoid the negative effects caused by dry glass or glass-coated plastic tubes. And medical-grade titanium tubes for preparation are used. And this has gained attention because of its biocompatibility and thick fibrin mesh network. And O'Connell described the unavoidable silica contact with LPRF tubes and with the regular tubes. So this PRF has come into existence. And the first human study of TPRF in the literature confirmed that the basic histological structure of TPRF is similar to LPRF, but however, the fibrin of TPRF seem to be more highly woven and thicker, which could be due to a better hemocompatibility of the titanium compared to glass, which could have potentially led to the formation of a more polymerized fibrin. And due to this hypothesis, TPRF lasts a bit longer in the tissue. And these are all the classic studies on TPRF stating its potential and evaluating the efficacy. And if you see the findings of each of these studies, most of the studies and almost all the studies were very effective in improved wound healing, and also has shown in the last study, you see, peri-implant tissue thickness TRF showed additional regenerative benefits based on clinical and radiographic criteria. TPRF showed potential for superior defect management even. And then coming to the advanced platelet-rich fibrin, that is the APRF, which is a fibrin enriched in platelets effective in stimulating the bone growth due to slow release of cell growth factors affecting the bone regeneration process. And this was first developed by Ganati. And how is standard PRF different from APRF? If you see the centrifugation protocols, the centrifugation protocol for APRF is lower, enhancing the time. Thereby, you have more platelets finding in the distal part away from the buffy coat. And hence, this concept of generating a fibrin-based gel-seeded matrix solely can be handled and modified easily in a short period of time, thereby providing the defect not only with a matrix permitting cell migration, but also crucial biological cues are provided, accelerating the wound healing process. And additionally, APRF also appears to be an ideal provider of autologous cells, especially neutrophils and macrophages, thus enabling mutual stimulation, creating a synergistic relationship in terms of interest in tissue regeneration. And then coming to the injectable PRF. This is a third generation PRF, which is fully autologous blood-derived biomaterial having a three-dimensional fibrin network like that of a PRF clot, while retaining the fluid nature just like the platelet-rich plasma. And the unique feature of this IPRF is it has predominantly collagen type 1 and lymphocytes along with the growth factors and platelets. And this is one study which has been recently published in 2020, evaluating the effect of IPRF in the initial treatment of chronic periodontitis, and which has shown that definitely it will not only enhance healing, but also improve the clinical outcomes in the treatment of chronic periodontitis. And IPRF in gingival precision coverage, these authors have conducted randomized clinical trials examining the injectable IPRFs, that is the injectable PRF, nothing but the IPRF, combined with microneedling for gingival augmentation in thin periodontal phenotypes, providing desirable results. Then these are the various studies of IPRF in bone regeneration, wherein even the osteoblast behavior and actions were studied for, and they concluded that it's definitely a more effective alternative to PRP for bone regeneration applications, and IPRF coatings can definitely improve osseointegration on titanium implants in a study conducted by Shah and Thomas. And PRF can also enhance bone regeneration when used with titanium mesh and substitutes, and it can enhance the efficacy of guided bone regeneration procedures. This was a case shared by Nandakumar sir in his clinical practice, wherein the evidence of bone regeneration or the bone fill was seen after 12 months after injecting the IPRF at the site of the defect. The main thing with IPRF is the sticky bone, which is the wonder graft, and this was the sticky bone that was prepared for incorporation into a defect in one of our own cases way back in 2015-16, which showed promising results, and the case has been also followed up for almost 10 years, which was published in the International Journal of Periodontics and Restorative Dentistry. And you can just go through this case report, wherein all the parameters were very clearly explained, with a 10-year follow-up, wherein we revised not only the soft tissue, but also the hard tissue as well. And then coming to the wound healing and anti-inflammatory efficacies of IPRFs, in vitro co-culture models have definitely shown that they definitely improve vascularization in bone tissue engineering applications, enhancing regenerative outcomes. And especially in palatal wound healing, IPRF has been definitely showing positive influence in the healing process by accelerating wound healing and reducing post-operative morbidity, showing superior properties compared to IPRF alone. Then the antimicrobial efficacies of IPRF. Again, IPRF has shown to be a more effective platelet concentrate for promoting antimicrobial defense and tissue regeneration. And the merits and demerits of IPRF. Over the merits, demerit is only thing is the limited application due to its small amounts derived from autologous blood. Otherwise, the merits are definitely very much higher compared to the demerits. And there are drawbacks of PRP and PRF membranes discussed from the conventional PRP, then the PRF, then the APRF, LPRF, IPRF. The main thing is they have faster than ideal resorption rate characterized within a 2 to 3 week time frame. And hence they cannot be utilized as barrier membranes similar to collagen membranes that we regularly use, owing their ability to extrude soft tissues over an extended period of time. And definitely they have a short in vivo turnover rate. But then to overcome these limitations, an interesting attempt has been made by Kawase and his colleagues in 2015, introducing a heat compression technique with PRF membranes, aiming to heat PRF to make it last longer and extending its working properties. And this heat compression technique extended the degradation properties of PRF to greater than 3 weeks, significantly longer than the standard 2-week membranes, which were completely resorbed later. And this led to the hypothesis that heating platelet concentrates, especially the platelet poor plasma layer rich in albumin, could definitely favor a slower degradation rate compared to the traditional PRF. And that's how, to overcome the limitations of conventional PRF, came the evolution of ePRF. And then albumin PRF protocol was developed mainly to overcome the quick degradation properties of platelet concentrates and better maintain volume stability. And that's how this advanced formulation of ePRF has come into the literature, addressing basically the limitations of conventional PRF by enhancing growth factor release and prolonging its biological activity. And this ePRF membranes definitely offers superior cell and entrapment and bioavailability, making it a promising tool in regenerative medicine. And this was introduced and developed by Dr. Richard Miron in 2021, and modified centrifugation technique improved fibrin cross-linking, extending the release of bioactive molecules, improving tissue regeneration over a longer period. And this is the biological composition of ePRF, wherein you have all the growth factors like FGF, IGF-1, TGF, beta, PDGF, and VEGF, having their own unique significant roles. And the mechanism of action of ePRF, this dense fibrin network allows for sustained release over 7 to 14 days compared to the rapid degradation seen in standard PRF. And because of this extended bioavailability definitely improved the healing outcomes in both hard and soft tissues. And the cellular interactions and healing mechanisms were much better because ePRF served as a natural scaffold with its lower degradation ability, thereby enhancing immunomodulation and reducing infection risk, thereby promoting faster wound closure. And these are the various clinical applications of ePRF, starting from socket preservation till implant dentistry. And also, literature has shown that ePRF enhanced periodontal regeneration and the reduction of inflammation and gingival recession management even. And its use has been extended. The extended PRF, as the name implies, has extended its use even to dermatology, skin rejuvenations, and hair growth stimulations. The main advantages of ePRF over conventional PRF are, to summarize, one is the prolonged growth factor release, higher cellular retention, more robust fibrin network, and completely autologous and biocompatible like any other PRF. But the limitations and challenges of this are the lack of standardization, the time sensitivity, patient-specific variability, and more evidence is needed to establish universal protocols for its application, because this is one of the most recently introduced PRFs. But then the future perspectives for ePRF are definitely promising with personalized PRF protocols, combination therapies, advanced centrifugation techniques, and expanded clinical applications. And then comes the HPRF, that is the horizontally centrifuged platelet-rich fibrin, which was developed by Weng in the year 2020. And it has emerged as an advanced method, just like our extended PRF, but over traditional, it is unique in its centrifugation techniques, unlike the traditional ones. And again, the applications, wound healing, bone regeneration, and soft tissue augmentation. And these are the various studies depicting the advantages and limitations as well. One of the most biggest limitation is still more clinical studies are needed to fully understand the long-term benefits of this PRF. And then coming to a novel method for, this is one of the key articles given by Richard Miron in quantifying and evaluating cell types in platelet-rich fibrin and an introduction to horizontal centrifugation. These are one of the few of the recent articles on, and the recent and very few articles on HPRF. And that ends the various generations of PRF. And now answering the main question which Ashita ma'am posed in the morning is, why is PRF considered as a rising star in periodontal therapy? I want to answer this with the evidences that I have today. And definitely I consider this as a rising star because it has gained significant attention in increasing use in periodontal therapy because of its biological advantages, practicability, clinical outcomes, and regenerative potentials. And one more statement which we usually hear in many conferences is this: is PRF really a regenerative solution, or is it really overstated? Answering that question, answering the last two questions of my presentation, is PRF the rising star, and why is it really overstated, and is it really being overstated? I have the next part of my presentation with all the recent evidences. This is one of the articles published in the recent issues of Journal of Periodontal Research, which is one of the most topmost cited journals in periodontology. He has given a very clearly amazing article on the narrative review explaining the 30 years of autologous platelet concentrates from PRP to PRF. And in this article, all the subsections, including starting from gingival recession till GBR, were covered with evidences, and it's a system. It's a narrative review, but then all the recent studies have been incorporated on, all the last 30 years studies have been incorporated in this article, stating the evidences of PRF in periodontal and implant therapy as well. And when studied for the use of PRF for gingival recession coverage, these were the clinical takeaway points in the various groups, when various groups, as mentioned there, CAF, CAF plus CTG, CF, CTG, CF, EMD, CF, AM, and all these were compared. They stated that CAF PRF should be considered as a treatment option when baseline keratinized tissue width is at least 2 mm, and there remains no demonstrated superiority between PRF, EMD, and AM in the treatment of gingival recessions, but current evidence suggests that all three modalities yield comparable clinical results. And these are the various articles that have been incorporated into that review as far as gingival recession and its PRF and gingival recessions were concerned. And then coming to use of PRF in periodontal regeneration of intrabony and furcation defects. These were the 5 groups that were analyzed, and all the articles since last 30 years have been incorporated, and they have been narrated into a review wherein all these 5 groups have been incorporated, and the clinical takeaway points were use of open flap debridement or PRF resulted in statistically significant reduction in PPD, and the addition of PRF significantly, the addition of PRF to open flap debridement or bone grafts significantly improved PPD, CAL, and reduced bone fill, and reduction in bone fill. And the incorporation of bone grafting materials as well as biomolecules such as metformin, bisphosphonates, and statins also led to statistically significant improvements in PPD, CAL, and RBF. And then coming to autologous platelet concentrates, and this was the main systematic review with meta-analysis, wherein they have concluded that use of PRF when compared to OFD alone, statistically, again, you have significant improvements in all the periodontal parameters, including the bone levels. And then coming to your use of PRF for ridge preservation. Here again, these 4 groups were taken: blood clot, PRF, FDBA, and FDBA plus PRF, wherein it was stated that the combination of PRF with a bone grafting material has shown a significant increase in vital bone formation compared with bone graft alone. And these were all the articles that have been studied to give that conclusion. And then use of PRF for the management of third molar extractions. PRFs enhances soft tissue healing, and they also significantly reduce the incidence of dry sockets and post-operative discomfort. And then after third molar extraction, I don't want to dwell into detail, but even PRF in these cases have been shown to be very promising. And one more important thing that fascinates every periodontist is, because we are more into implantology, the use of PRF in sinus floor augmentation. Clinical, 2 groups, especially the bone grafting material alone or in combination with PRF, and PRF as a membrane for lateral wall closure, wherein we have favorable clinical results have been observed and recommended for narrow sinuses less than 10 mm. And again, in controlled studies, implant stability coefficient values were found to be equivalent between graft sites grafted with PRF and those using a collagen membrane. And again, PRF has significantly reduced patient-reported post-operative pain and swelling. And these were the articles considered to give the clinical takeaway points. And this is a very good article in Journal of Periodontology, which was published way back in 2014. And again, simultaneous sinus lift and implantation using micro-threaded implants and leukocyte and platelet-rich fibrin as a sole grafting material, a 6-year experience, and which has shown that the systemic use of PRF during sinus lift with or without bone grafting material may be beneficial, particularly from the protection of Schneiderian membrane, and should be analyzed in further studies. And then the crestal approach to sinus floor elevation for atrophic maxilla using PRF as the only grafting material, which was a 1-year prospective study, and it showed that it promoted endosinus bone gain when used as a grafting material in the crestal approach to sinus floor elevation. And again, sinus floor elevation, an early report on 110 patients presented for localized sinus floor demonstrated a high degree of safety and success at sites, especially between 5 to 8 mm of reduced subantral bone height. Then coming to use of PRF for guided bone regeneration. Although we have unlimited data comparing various randomized controlled trials evaluating the role of PRF in GBR procedures, PRF has definitely shown to promote early vascularization of bone tissues, which is a critical factor for successful new bone formation, and it should be applied as an adjunct to collagen barrier membranes positioned in direct contact with soft tissues rather than being used as a primary substitute for traditional barrier membranes. And these are all the evidences depicting the same. And this is one narrative review on APCs during alveolar bone augmentation. And this is one more critical sized bone defects regeneration using a bone inspired 3D bilayer collagen membrane in combination with LPRF, which was an in vivo study. And results have shown that 3/4 of the defect was filled with lamellar bone when compared with LPRF. And then coming to use of PRF around dental implants, definitely PRF has contributed to enhanced primary implant stability. Although limited available data exists that PRF may improve soft tissue healing around implants. And these are the articles stating that the application of LPRF membranes in the osteotomy site of an implant may produce clinical effects at the early stage of healing by promoting early implant stability and reducing marginal bone loss, but wherein long-term effects need to be still observed. And this is one of the studies wherein PRF on peri-implant soft tissue, this was one of the earlier studies conducted in 2015, that PRF could be considered as a healing biomaterial with potential beneficial effect on peri-implant tissue, and it can also be used as therapeutic adjuvant in clinical scenario. And the effect of platelet-rich fibrin on implant stability, it stated that definitely platelet-rich fibrin application results in improved implant stability, especially in the first week of osseointegration. It was published in the International Journal of Oral and Maxillofacial Implants. And one more study, does platelet-rich fibrin increase the stability of implants in the posterior maxilla? Definitely, PRFs have increased the enhancement of post-insertion stability placed in the posterior maxilla during the healing period. And these are also the most recent articles on APCs, and all of them are in the last 3 to 4 years. And this is a very good article wherein it was published in the Journal of Periodontology 2000. It was a systematic review with meta-analysis wherein you have the use of PRF compared to open flap debridement alone led to statistically significant improvements in PPD detection and cal gain. And this is one efficacy of new generation platelet-rich fibrin in the treatment of periodontal intrabony defect. This was the article wherein you have improved bone fill and bone gain and cal gain. And again, this one article wherein clindamycin was augmented and stating that IPRF with minimally modified invasive surgical technique provided significant clinical and radiographic improvement up to 9 months. And again, this is one of the significant articles published by Richard J. Miron, the inventor of extended PRF, who stated that, who has done an extensive review on the treatment of periodontal intrabony defects, a systematic review and meta-analysis, wherein it was compared to OFD alone and statistically improved clinical outcomes were definitely obtained. But then again, future research needs to be geared towards better understanding potential ways to enhance the regenerative properties of PRF with various small biomolecules which may prove valuable for future clinical applications. And definitely future research investigating PRF at a histological level is definitely needed. And in this article, in the treatment of intraosseous defects of stage 3 periodontitis patients, the use of low-speed PRF in conjunction with open flap debridement improved cal and pocketed post-surgically and could provide a cost-effective modality to augment surgical periodontal therapy of intraosseous defects of stage 3 periodontitis patients. And again, this was an Indian study wherein the evaluation of titanium PRF, TPRF and leukocyte PRF in the treatment of intrabony defects was conducted. And under the limitations, this study showed that both TPRF and LPRF improved clinical parameters, indicating that they are useful in soft tissue healing. But then due to more bone fill percentage by stimulating the osseous cells, TPRF definitely helped significantly in hard tissue healing compared to LPRF. And these are few PRF protocols wherein growth factors were delivered and cellular activity was measured for. And this is one of the significant articles published in European Journal of Dentistry in the year 2020 on platelet-rich fibrin in coverage of gingival recessions. Then assessing the effectiveness at advanced platelet-rich fibrin again in treatment of gingival recessions, which has shown that definitely APRF is a better clinical option to improve the outcomes of treating gingival recession. And this is a review on stability of dental implants, and it has shown that PRF is effective in improving secondary implant stability, and implants with or without LPRF, a systematic review on dental implants, wherein again it has shown to accelerate the healing process and improve patient outcomes undergoing implant surgery. And one of the most interesting articles that was published in 2022, which was a bibliometric analysis of platelet-rich fibrin in dentistry, wherein total 562 PRF related dental articles were included, and only full articles were included. And the database was Web of Science, and wherein the key words and the trending analysis was on bone regeneration, wound healing, periodontal regeneration, and implant osseointegration. And interestingly, a sharp rise was observed in the last 5 to 7 years, showing growing interest in PRFs. And this indicates that definitely PRF is currently an evolving and trending topic in dentistry. And in this article, in this bibliometric analysis, the study designs were used were the clinical studies, RCTs, and review and meta-analysis, which definitely shows that PRF research is not just limited to lab or in vitro, but it's being used very actively clinically also. Because then only you had all these original research articles contributing to 58% in this bibliometric analysis. And in this article, all the common clinical applications which were addressed were dental specialties using PRF, like oral surgery, periodontics, and implant dentistry, which supported the evidence-based dentistry, and wherein you had extraction socket sealings, intravenously periodontal defects, sinus lift procedures, and gingival recession coverage. And interestingly, the most productive countries in taking forward the PRF research are Turkey, India, and China, which are the developing countries contributing to major countries to PRF research. And I don't think we can tell India and China as developing. They are definitely developed. And this article has quoted all the highly cited authors and institutions that showed strong international collaboration, which increased the research impact for this article. And before I conclude, I just want to quote our studies that are published from Team Perio at VDC on PRFs. We have almost 10 to 15 studies which were already published. This was one study which has been published in the Clinical Advances in Periodontics on the peri-implant mucosal enhancement using leukocyte PRF under SON-sponsor technique, a randomized controlled trial, wherein leukocyte PRF enhanced peri-implant mucosal thickness and aesthetics, making it a viable option in implantology. You can go through these articles at leisure. And one more study on role of titanium, it's a systematic review on the role of titanium reinforced platelet-rich fibrin in periodontal tissue regeneration, wherein it was stated that the systematic review that definitely TPRF is a valuable biomaterial for periodontal regeneration, but further clinical trials are definitely needed. And one more study on the comparison of the effectiveness of DFDBA and TPRF in the regeneration of intramonic defects, wherein TPRF has shown promising alternative to DFDBA for intramonic defect regeneration due to its biocompatibility and regenerative potential. And all these are very much done in our department. And one more study, injectable platelet-rich fibrin with microneedling in enhancing peri-implant mucosal phenotype, which is a prospective clinical trial, which was recently published in the Journal of Oral and Maxillofacial Surgery, Medicine, and Oral and Pathology. which stated that IPRF plus microneedling is a potentially effective non-surgical, minimally invasive technique to enhance peri-implant mucosal thickness. Then one of the recent studies published in GIST was on frozen advanced platelet-rich fibrin as an adjunct to the modified tunneling technique for root coverage, which was a pilot RCT, and stated that frozen PRF showed better root coverage, mechanical properties, and patient-reported outcomes than APRF. Therefore, frozen PRF can be considered as an alternative in the treatment of gingival recessions even, but then further trials need to be conducted. And one more, it was an in vitro study on the impact of storage protocols on the mechanical and structural properties of frozen platelet-rich membranes, wherein frozen platelet-rich membranes showed improved mechanical properties, specifically in terms of tensile strength and elasticity compared to APRF alone, overcoming some limitations of conventional PRF. Then this was one study published in World Journal of Dentistry, wherein you have the efficacy of autologous concentrated growth factor enriched bone matrix in treatment of periodontal intramolar defects, which has concluded that combining CGF concentrated growth factor with DBM is more effective than DBM alone in treating intramolar defects in periodontitis patients. Then coming to Journal of Dentistry Indonesia, in this article was published wherein a systematic review on the role of titanium reinforced platelet-rich fibrin in periodontal tissue regeneration was considered. And again, we had a prospective clinical trial on clinical and patient-reported outcomes of periodontal phenotype modification therapy using IPRF with microneedling and pre-gingival grafts, a prospective clinical trial, wherein IPRF plus microneedling may lead to non-inferior clinical outcomes after 6 months with better patient-related outcomes compared to more invasive pre-gingival graft protocols in phenotype modification therapy. And here comes one more an ex vivo observational study comparing the structural, mechanical, and histochemical characteristics of LPRF and TPRF membranes using different centrifugation protocols, which was found that a significant difference was observed between LPRF and TPRF at 3,200 RPM and 2,700 RPM protocols. And this was published again in Journal of Oral Surgery Pathology. And then coming to this study on efficacy of locally delivered simvastatin combined with APRF in treatment of intramolar defects showed that both groups showed definitive parameter improvements in all parameters. And then this was one study that was published in Clinical Advances in Periodontics, which I already discussed. And this was one study which was published in Contemporary Clinical Dentistry on Vista technique with PRF compared to subepithelial connective tissue graft for the treatment of multiple gingival recessions. And this is one study which has been recently accepted and on the verge of publication on clinically evaluating the peri-implant mucosal enhancement using leukocyte and titanium platelet-rich fibrin with Son-sponsor technique, a randomized clinical trial. And so with all these evidences that have been discussing in the last 1 hour, definitely I would like to conclude that in summary, the clinical consensus and a wealth of research available in the literature today support that PRF has served as a scaffold and a gold standard not only in dentistry but in various fields of medicine. While its predecessor PRP paved its way, PRF has emerged as the ultimate 100% revolution in dentistry because of its universal biopotency, sustained release, and safety and superiority. Thank you. The session will be continued by Dr. Kumar sir, who will be introduced by Dr. Srihari sir on the enthusiasm on PRF.
Good morning, everyone. First I have to thank the Vishnu Dental College for giving me an opportunity, and special thanks to Madam Gautami Madam, who is energetic and giving an opportunity to this. It is immense pleasure to introduce Dr. S. Muthukumar, who is working currently as a professor in Sri Ramachandra Dental College. He completed his BDS from Meenakshi Ammal Dental College, Chennai, and completed MDS from Sri Ramachandra Medical University and did his PhD on implantology. He is the first dentist in the country to be awarded with clinical PhD in implantology as an independent research scholar. And he has delivered more than around 75 lectures in national and international conferences. And he has conducted a live surgical demonstration on Perio aesthetics for the first time in the country as part of his pre-conference courses for the 17th ISP National PG Convention that was held in Chennai. And he was also the winner of the Perio East Challenge of Piezo Surgical Procedure in national level involving more than 120 teams from the top 15 dental colleges of the country, and was awarded as a best poster in clinical implant research category in the national level of 10K implant symposium that was held on September 18th, 2021 on Savitha Dental College, Chennai, and was also awarded as a kit of ostium implants for 2.5 lakhs. And he is also keen interest in the research, particularly on dental implants, related researches, periomedicines, molecular markers in periodontal diseases, periodontal microbiology, perioplastic and aesthetic research surgeries, and particularly in regenerative periodontal therapy and tissue engineering. I welcome you, sir. I welcome Dr. Muthukumar Gautami to the stage, sir.
Sir, kindly unmute yourselves.
He has to join yet.
On the video. Sure. So, am I audible?
Sir, you can on your video, sir.
On the video.
So the video is on, madam. We can see you.
You're able to see? Yeah.
Yes, sir.
Right.
You can continue.
Very good morning to one and all. The topic given to me is autologous platelet concentrates in periodontics. It's an enthusiasm. So before going into the topic, we talk with a lot of evidences which in the previous presentation we have seen, which show that it is used in periodontal regeneration, okay, in various forms. So first, there is a need to understand that when we speak of periodontal regeneration, we need to regenerate bone, PDL, cementum, as well as the most important thing here is we have to regenerate PDL as well. When we speak of PDL, we know it's a dynamic structure with complex cellular network which operates to have it in a non-mineralized state. Basically, it is a non-mineralized structure, a soft structure. It is embedded between the cementum and the bone, which are mineralized structure. So this is an important hypothesis put forward by Ishikawa. So where he has told that the small tilting mechanism which happens at cellular level to the osteogenic cells can take it to a mineralized state or non-mineralized state. So this balance should be maintained irrespective of whatever biomaterial we are going to use. And there are different signaling mechanisms and growth factors which help in holding it in a non-mineralized or non-calcified state, I mean the PDL here. So with that lead, how PRF functions generally, how it works. It is based on the concept of endogenous regenerative therapy. PCS, that is platelet concentrates, leads to tissue regeneration by cell recruitment from the extracellular matrices as well as from cell homing from peripheral blood vessels. These are the two concepts, cell recruitment and cell homing. So the focus of this presentation is to highlight the limitation and lack of conclusive evidence supporting the platelet concentrates effectiveness in periodontal regeneration, and how I am going to disprove the hypothesis of effectiveness. The hypothesis of effectiveness of platelet concentrates from all the literature which Madam has shown is it enhances healing. It accelerates tissue repair and regeneration by releasing growth factors to the site of healing. And the second concept hypothesis is its regenerative potential. That is, it stimulates the regeneration of lost periodontal tissues, including bone and ligaments. So, logical reasoning why it is ineffective. Number one is technical reasons. That is, lack of standardization, application variability, cost versus benefit, and patient factors. And number two is biological reasons, where we will be discussing on fast degradation rate, poor mechanical properties, inconsistent growth factor release, and structural integrity. So first we go into the technical reasons. When we speak of technical reasons, a lot of literature has been published, which Madam enumerated in the previous lecture. So all of them have been deemed to be ineffective as quoted by Miran and Kobayashi after this paper in February 2024 in Perio 2000. Okay, where they have seen this, they have not standardized on the lab, various centrifuges and test tubes, which was highlighted by Ashita ma'am during her presentation. And they have published thousands of clinicians not utilizing appropriate centrifugation protocols to produce PRF, and even worse is numerous scientific publications which was enumerated in the previous lecture. And there was, if they are not following these protocols, there is going to be alteration in the RCF or G-force values, which will eventually lead to uneven distribution of platelets and growth factor, which impact regeneration or healing in general. So based on this consensus report by Miran and Kobayashi, unless a paper has these 5 points in that, what are the rotor radius or dimension of the rotor which was used in the centrifugation mission, angulation of the rotor that holds the tube, RPM and RCF for that particular mission, how it was calculated, and composition and size of the tubes that were used, and which model of centrifugation that was used. Okay, they are not mentioned. Those papers are deemed to be ineffective from 2024. The first thing we will see is rotor radius or angulation, how it impacts. So there are two things. There is centripetal force, which obviously acts at the center, and the centrifugal force, which is applied on the test tube when the apparatus actually centrifuges. Okay, so this force will be detrimental in separating the cells, based on which the growth factor concentrates and release profile will be determined. So when we see the rotor radius, here you can see in the picture, one is a fixed angle and one is a horizontal centrifuge. When in the fixed angle, you see there is uneven separation of cells, which most of the studies use this fixed angle centrifuge with a force of 200 G force at the level of clot in both. But when you see at the level of apex, it's 700 with the horizontal centrifuge and 400 with the fixed angle centrifuge. So original PRF rotor radius is 5 centimeter. We all of us take into consideration the RPM and RCF based on Chokran's criteria, okay, or Miran's criteria. But we apply that into our own missions, which don't give the same results because of this. One is the rotor radius should be around 5 centimeter. Lab tech centrifuge, Remy R303 and swing bucket, which are common in Indian colleges and practices, they have different rotor radius. They don't produce the same amount of cell separation and growth factor release. Second thing is clinical implication. What this G-force is going to have. Most of the time, the recommended G-force is around 430 to 750 G. But when we are using centrifuges with rotor radius with 7.5 to 12, you get around 700 to 1000 G-force, okay, which is not optimal. In fact, they damage the cells. So most of the traditional centrifugation schemes are fixed angle centrifugation, which presents a drawback in terms of accurately separating the cells based on density. So most of the times, as all the papers with the evidence which were discussed, they use this interlock system, which has 33-degree angle. So the suggested thing is 90-degree angle or a horizontal centrifugation concept. So what happens is, when you see in the proximal aspect, you see that the cells are not separated like how it is in a horizontal centrifuge. In an even manner, you see this, they are at an oblique angulation, so that they don't have uniform separation of cells. The second thing is, when you see the distal view of the same centrifugation, the fixed angle centrifuge, you see a lot of destruction of cells. You can see even some amount of red blood cells that have been coming up. Whereas when you use horizontal centrifuge, that will not happen, because cells don't disintegrate when you use a horizontal centrifuge. This will have a detrimental effect on the release profile of growth factors. So next, coming to RPM versus RCF. Now coming to the point that we are having only Indianized version of centrifuges. Obviously, what Chokran and Miran are using, they are going to be very expensive. So how you calculate the RCF values? They have derived at a formula. That is, use this 11.18, which is standard, the rotor radius for that particular centrifuge, irrespective of whatever centrifuge you use. N is the constant by 1000 whole square. Okay. Based on this, when you use to an extent, okay, we can replicate the centrifugation force as well as the growth factor concentrates as described by Chokran and Miran. So as the concept says, when we go for slow speed centrifugation, that is 7.8 to conventional PRF to 60 to IPRF, the inflammatory cells and growth factors go up with low speed centrifugation concept. Over the years, it has evolved from LPRF, okay, to other formulations, to currently the extended PRF, HPRF and extended PRF. Now, when we see at LPRF protocol, as discussed earlier, this is an important paper by Miran and Kobayashi, where they say the importance of using the proper protocol RPM and RCF. When we use low speed centrifugation protocol, you see the cell separation as well as the membrane size is much smaller. When we use slow speed centrifugation, for example, the APRF protocol, the cell separation as well as the membrane is thicker. So what they say is, they have compared 24 different protocols to identify the correct centrifugation force for membrane form of PRF and liquid formulations of PRF. As suggested by Miriam and Kobayashi, they say that 700 RCF. Remember, I want all of you to note the point. It's not RPM, it's RCF. 700 RCF for 8 minutes for solid membranes and clots, and 200 to 300 RCF for 5 minutes for IPRF, and 2000 RCF for 8 minutes for CPRF. So when we follow this RCF, we get optimal growth factor release profile. Okay, this is based on the calculation which I showed. When we have high RCF, we have less leukocyte content, okay, and more of growth factor content, as demonstrated in APRF plus and APRF. When you go for a low RCF like APRF and IPRF and CPRF, the growth factor concentrate is going to be more, and the leukocyte concentration is going to be less. So IPRF and CPRF contain more growth factor concentrates compared to your solid formulations of PRF. So another important factor apart from RPM and RCF is what tubes we are using. So we know that for concentrated growth factors, plastic tubes are used, which are silica coated, compared to glass tubes, which are used for APRF. So in this study by Nakamura, they compared the CPR, the concentrated growth factor protocol, with your APRF protocol. Okay, they showed that in the plastic tubes, when it is used, they don't get the same amount of growth factor release profile. They segmented the PRF membrane into different parts, and also found that the membrane that is immediately adjacent to the red blood clot, that is where there is maximum concentration of PRF. You cannot take the membrane and think the concentrate is same at all levels of PRF. So this experiment shows that the tubes also play a part, and it is more concentrated towards the red cells compared to the superior compartment. Okay, so the distribution of growth factors is not even even in the same PRF gel we get. So coming to the significance of glass tube in PRF formation. When we speak of PRF formation, the most of the time it follows the intrinsic pathway, because it is in vitro. We are stimulating blood clot formation in the test at a test tube level. So the rate limiting step is when the blood comes in contact with glass. Okay, it activates factor 12 to 12A, eventually 2 to 2A, formation of thrombin, resulting in a fibrin clot. On the other hand, extrinsic pathway, what happens in vivo is the core is platelets, where you have a primary platelet and secondary platelet formation. So this is why conceptually this fibrin scaffold is formed compared to when it happens in vivo. So, and also we know there is the composition of growth factor is supernatural in vitro when we prepare this PRF compared to in vivo scenario. The reason being, this follows the intrinsic pathway with core being the fibrin, and that follows in vivo its the extrinsic pathway, the core being platelets. Coming to the composition and size of tubes utilized to produce PRF. Okay, so as I mentioned earlier, the tube should be given clearance by FDA and CE to run PRF. Most of the laboratory test tubes what we use are cheaper, and most of the times they are coated with chemical additives, even if it is a glass tube, or they have silica or silicone, which gives unpredictable outcome. So the study by again Miran and Kobayashi, they showed that PRF clots generated are smaller due to penetration of silica particles. Not only that, they are cytotoxic to human periosteal cells. Cells of osteoblast lineage take up silica, and they showed to have high affinity for cell membrane walls, eventually leading to apoptosis of the osteoblastic lineage cells. So this is the implication of using silica coated tubes, which most of the literature has used up to 2024. After the guidance by Miran and Kobayashi, now they are going for pure glass tubes which are not coated. So next, coming to comparison of protocols, high speed protocol and low speed protocol, using different, a comparison of platelet rich fibrin produced using 3 commercially available centrifuges. Does all centrifuges yield same type of growth factors, or they produce same type of PRF membrane? This study answers. So in all the 3 machines which were used, there is one was the intraspin machine, where it was a fixed angle with 33 degrees, and this is a duoquattro machine, which is called as process for PRF, which had 41.3 degree angle, and next is a Salvin centrifuge, which used 45 degrees. So PRF tubes were critical. Among those tubes, as you can see, the weight in grams as well as area of PRF clot was more in process for PRF machine compared to other. This is something to do with the angulation. Both for the low speed protocol as well as the high speed protocol, the volume of membrane and weight of membrane that was produced was more in process for PRF machines compared to intraspin and Salvin dental, which clearly stated that the growth factor concentrates also will be proportionately more in process for PRF, which shows the importance of using the correct PRF machine. We cannot claim that we have done n number of publications with whatever centrifuge we have and whatever tubes we are using. Second is centrifugation machines and tubes. So they compared the different centrifugation machines and different centrifugation tubes. The tubes again from the same 3 companies. Okay, they used the same tube. That is, for example, if they use intraspin tube, they used the intraspin tube in all the 3 machines, and they found that tube wise the process for PRF tube, they yielded optimal PRF concentrates which had good release profile of growth factors. On the other hand, when they compared the machine, the intraspin machine was optimal. Okay, they produced a good weight in grams as well as good quality of PRF. So not only the type of machine, but also the tubes play a part in producing optimal growth factor concentrates. Okay. Next, the impact of centrifuge characteristics, which is understudied. RCF, RPM, which we discussed, then the different centrifugation protocols, the tubes and the machines we saw. But one thing which has not been studied extensively until this paper by Dohan and first was the vibrations that is produced by the different machines. Okay, they showed that each machine had its own profile of vibration, which affected or impacted the architecture and cell content of LPRF clot, which revealed a considerable flaw in all the PRF literature until this parameter was touched upon. Okay, so this dated back to 2017. After that, some of the papers mention about the vibrations produced by the machine. So these are the papers which are really valid and which can be considered. So the various centrifugation models they used was 4 different centrifugation machines they used, and they evaluated the sizes based on vibration. Okay, you can see the difference in sizes of PRF clots from large to medium to small. Following the same protocol, drawing the blood from the same individual with the same type of tubes. This is due to the impact of vibration of the machine. So that impacted the release profile also. When it is fully loaded and partially loaded, they saw the vibration. Okay? And they saw that the intraspin machine had the least vibration, and they had the maximum growth factor concentrates compared to other machines. Next, coming to the physical factors affecting the size of the membrane. First is the effect of time on PRF membrane. Most of the time, as postgraduate, you prepare the PRF, then you elevate the flap or you wait for 10 minutes, 15 minutes. For you to know that the average size and as well as the release profile is impacted within 0 to 30 seconds, you will have to use once it is prepared. That is almost immediately. After that, it tapers off by 6% from 30 to 60 seconds. That is up to 1 minute, it is acceptable from preparation to usage in the oral cavity. After 1 minute, if you see, it goes down by 13%, and if you wait for 2 minutes, 23% is lost, which means whatever studies which have been done in vitro cannot be taken into account for in vivo because of the lag in time by which next is bigger membranes, males or females. So when sex was compared, the normal hematocrit value in men was 40 to 54, and in women it was 30 to 68. So lower the hematocrit value, the membrane was larger. So most of the studies had a mixed bag of male and female participants. Okay, evenly distributed age and sexes were not taken. So this is the impact of not checking it gender wise. Next is bigger membrane in younger or older. Generally, the answer given is older, because in older individual, again, the hematocrit value is less. Membranes are bigger, but growth factor concentrates will be definitely less compared to your younger. Even though the membrane is lesser in size in younger individuals, the growth factor concentrate will be more. Then the next segment of it is biological reasons. What are the biological reasons for not accepting the current literature evidence? Number one is which component of the cell, that is the leukocytes, platelets, or the fibrin, which plays a part in regeneration? That is a $1 million question which is still not answered. Okay. Now, the basically how this PRF helps in regeneration is the growth factor stimulates the stem cells which proliferate. Okay, and they bring about the regeneration to happen. They also act on undifferentiated mesenchymal cells and allow them to proliferate to the lineage of cells that need to be regenerated based on the type of defect where you are going to place. Now, currently, how it is applied is the various formulations that have been discussed for different type of clinical use. For the same type of platelet concentrate, you cannot use for all clinical scenarios. Second is the rationale behind using this is PRF is a natural scaffold where it has not only the scaffolds, it works, it's a natural tissue engineering construct where you have cells, scaffolds, as well as signaling molecules in the form of growth factors. But how it is workable in vivo scenario for regeneration. So there's different growth factors which are present in PRF. They have specific function. All these growth factors, they are supposed to be in optimal concentration for the tissues to respond at different time points of regeneration or tissue healing. Obviously, we have a hemostatic phase, inflammatory phase, proliferation phase, and maturation phase when it comes to healing of a tissue, for that matter, regeneration. So will they be optimally available in all these phases? That is again a big question mark. In bone regeneration, how this PRF is hypothesized to work is they act upon the undifferentiated mesenchymal cells, which regulate osteogenesis through the signaling mechanism by acting on the different pathways. For example, the VEGF, which is present in platelet concentrates, they are supposed to have an impact on MAPK ERK signaling pathway. Similarly, PDGF-BB on Wnt beta-catenin signaling pathway. And again, PDGF-BB on P13-AKT signaling pathway. All of them through stimulating the mesenchymal stem cells. The problem is the specific molecular signaling transduction process or mechanism have not been fully elucidated so far to actually say that whether it can be extrapolated in a clinical scenario. So this is a heat map of a study by Zhu et al. Where they have shown that all the growth factors which we saw, okay, is only to optimal concentration. The area marked in red, okay, they show the optimal concentration for regeneration. That is present only for 24 hours. When it goes beyond 24 hours, it's not, which means that they may help in the initial phase of healing, hemostatic phase, not more than that in the regenerative phase. Why growth factors don't work in a clinical scenario? Because, you know, when we speak of regeneration, we have, as I told, the different stages: vascularization, cytodifferentiation, ECM synthesis, proliferation. And all this, we have different growth factors and different signaling mechanisms as discussed, for which we need optimal concentration of growth factors, which is not going to happen in an in vivo scenario. Again, coming to the role of cells, okay, obviously it's based on the principles of cell separation and separating the platelets and leukocytes from the red cells. Density wise, we know that platelets are less compared to other cells, so it's easily separated. So when we see in which phase of wound healing or regeneration these platelets are going to be effective, it's only up to the initial 1 to 2 days. That is the initial hemostatic phase. In the inflammatory phase, proliferative phase, it's more of lymphocytes that is going to take over. So the actual regeneration happens by the lymphocytes, not platelets as it has been thought. So how it can be applied to a clinical scenario? This principle of osteomax, okay, where there is macrophage polarization which happens. The macrophages, as we know, it is derived from monocytes, okay, and most of the time we say when the healing is from multinucleated giant cells, then it means that no, it's more of a fibrosis. That's not the fact. Even MNGs show lot of markers related to regeneration. So we have basically M1 macrophages and M2 macrophages. These M1 macrophages are pro-inflammatory macrophages, which doesn't allow tissue resolution, and the M2 macrophages are tissue resolution macrophages. So when you use this leukocytes, we'll have to see the expression of this markers, okay, whether they have this pro-inflammatory or tissue resolution. If at all, when this M1 phenotype is going to be upregulated and M2 going to be upregulated in a clinical scenario. So coming to the role of leukocytes and platelets, the PRF significantly inhibited the M1 macrophage. Okay, this is how it helps in regeneration. That is, it reduces the pro-inflammatory phase, okay, of macrophage. So which is shown by markers like TNF and IL-6. Okay, they inhibited the activation of M1 through NF-kB signaling pathway. On the other hand, PRF was supposed to promote M2 macrophage by expression of markers like RG1 and CD206, which activated the TGF beta signaling pathway, which facilitates regeneration. So this is the concept that has been hypothesized. And again, on antimicrobial related mechanisms, obviously they have antimicrobial properties, antibacterial as well as bactericidal activities, the leukocytes which they possess. Apart from that, platelets have antimicrobial property by producing oxygen metabolites, including superoxide, hydrogen peroxide, and hydroxyl radicals, which they release. So, but the problem is when leukocytes are there, okay, they produce a lot of pro-inflammatory cytokines, which negatively influence type 1 collagen and alkaline phosphatase synthesis by osteoblasts. This is why we say, you know, without leukocytes, we don't have platelet concentrates. If leukocytes are there, they prevent the cross-linking of fibrin mesh. Okay, so it's going to have an impact on based on how much of leukocytes are present, and the polarization of macrophages. Whether this is going to be actually impactful in regeneration or not is a big question mark. Next is coming to the scaffold part of it. We saw the cells and growth factors. The scaffold part of PRF, how it helps. So mostly we know that the fibrin matrix, which forms the scaffold, though it has a structural glycoprotein which helps in neovascularization or helps in promoting vascular regeneration, apart from embedding all the growth factors, okay, and also the cytokines within it. The problem with this PRF membrane is it lacks rigidity, okay, and when we use in vivo, most of the studies show in vitro the degradation time, etc. In vivo, when a lot of enzymatic activity is going to happen, they digest even more fast in real life scenario. Moreover, they lack rigidity, okay, so it can be used only as a healing biomaterial, but the regenerative potential is a big question mark, especially in vivo, for this specific reason. So why they don't work in clinical settings? The potential concentration of platelet concentrates include the possibility that the released cytokines may not sustain tissue regeneration for prolonged period, and that platelet membranes are vulnerable to mechanical stress, limiting their surgical applicability. So based on this, there is an important article by Kobayashi which shows that the release profile, the differential release profile of various growth factors were evaluated, where they showed PDGF-AA at the highest release profile even up to 1 week. Okay, even that was not in enough concentration for regeneration activity to happen. The earlier time points, 24 hours to 48 hours, the release profile was adequate. So the slow release of growth factors, sustained release of growth factors is essential over a 2 week or 3 week period at least for some sort of regeneration to happen. Based on this is our own paper which has more than 100 citations, okay, just published in the Journal of Biomaterials Research. We analyze the mechanical, chemical as well as structural analysis to know the impact of this mechanical, chemical and structural analysis on the release profile of platelet concentrates. We took into account LPRF, APRF and TPRF. This again is an in vitro study wherein tensile strength wise TPRF had the maximum strength, followed by APRF and IPRF. And degradation wise, again, the rate of degradation was more for LPRF compared to APRF and TPRF. And at a microscopic level, the fibrin architecture was more denser in LPRF or your standard PRF compared to your APRF and TPRF. The idea being that if it has to be porous for neovascularization to happen, at the same time it has to be rigid. Okay, so this was fulfilled only by APRF from our findings. But here you see this chart, the release profile wise at earlier time points. Okay, there was good release profile from APRF as well as TPRF. As the days gone down, okay, around 3 days to 10 days, the growth factor release profile tapered gradually, which may not help in regeneration. So the next important evidence which says that these platelet concentrates are not effective is the proteomic analysis, which was done, okay, by Reinhardt group, where they have shown that the proteomic analysis of human stromal cell secretome and compared that with LPRF. This LPRF, they showed the proteins associated with immune modulation, coagulation, and platelet function with no regenerative proteins that were present. So whatever regeneration that happens with platelet concentrates is because of immune modulation rather than its own regenerative potential. Based on this, we did a study which was published the last month, 2026 January, in the prestigious journal of BBA Proteins and Proteomics, where we have seen the comparative proteomic release of APRF, IPRF, and TPRF, where we have correlated that into functional divergence and clinical potential and assessed it accordingly. So our study showed that APRF was enriched in coagulation-related pathways, while IPRF was linked to lipid metabolism and immune signaling. Okay, so this is the PPN chart, the protein-protein network chart from our study, which showed that there was proteins which enriched immune modulation, coagulation, and platelet function. So if at all there is going to be any regeneration because of platelet concentrates at a proteomic level, it is only because of immune modulation, not because of its inherent regenerative potential. So how, if at all, how it can be made workable in a clinical scenario? Okay, expanding its application. And also some of our seniors, Ashita ma'am and Paul sir, were quoting in medically compromised patients how to use, etc. The answer is allogenic platelets. Answer is allogenic platelets, which we are working, which is our next work, which will be published shortly. Allogenic platelets, platelet lysates, platelet extracellular vesicles in cellular therapy. Okay. The concept is you take blood from all the individuals, even in a patient who is not medically compromised. Okay, their release profile varies, as I told, based on age, based on sex, not only systemic disease, environmental factors. So we cannot extrapolate the literature in a clinical scenario based on whatever has been done by Chokran or Mayran or whoever has does it anywhere. So to have a standard release profile, optimal concentration, we will have to use allogenic platelet concentrates, especially when we get a whole blood donation in a blood bank type of scenario. You have to go or from, it can be from a pooled blood sample, or it can be from a single donor. Okay, and you can pool it. And this unused or expired blood which have been given for transfusion, from that we derive platelet lysates by free thaw cycle, and also we extract platelet extracellular vesicles and other platelet components, which can be used in cell therapy, regenerative medicine, and drug delivery vehicle. So the potential other important area is lyophilized platelet concentrates. It was demonstrated that one of the shortfalls for platelet concentrates is, as I told, it should be used within 1 to 2 minutes. Okay, otherwise you don't have the release profile, nor it can be stored, or it cannot be used in an emergency situation. So for lyophilization is nothing but freeze drying it. The concept I will share with you. It was demonstrated that there is a higher release rate for 4 weeks and up to 6 months when platelet concentrates, which is allogenic, is lyophilized and used. Okay, so fabrication of lyophilized platelet concentrates will be like drawing blood as per the usual protocol, and it has to be centrifuged at 300 rpm for 12 minutes, and this is using that particular platelet, centrifuge, not in any centrifuge which we have. Okay, and then following cell separation, it can be on the derivation of membrane, it should be lyophilized overnight, and it can be formed in the form of a granules. Okay, and then they can be used for regeneration. It can be used along with bone grafts, along with membranes, coating on implants, etc. The emerging role of platelet concentrates, apart from that lyophilized platelets, is platelet extracellular vesicles. Okay, so this extracellular vesicles, when we speak platelet concentrate as a whole, I told you one of the limiting factor of using platelet concentrate is presence of leukocytes, okay, which has pro-inflammatory cytokines, which are detrimental to the collagen network present in platelets. When we derive only the platelet extracellular vesicles, we just have the growth factors and the mRNAs, which help in intracellular signaling mechanism, which help in regeneration. Okay, so you have derivatives of platelets only, or secretions of platelets only. It again involves ultracentrifugation method and high level cell separation for us to get this platelet extracellular vesicles. Another thing which has been largely popularly talked about is the EPRF membrane. But the problem with this extended PRF is denaturation. Okay, because you have to heat it and then cool it. They lose their activity, and also the cells and growth factor undergo apoptosis. And there are very limited human studies, and extending the resorption properties for this EPRF, other cross-linking agents have been worked upon, and also to enhance the release profile, small biomolecules are being added. And how it can be used now is, like I told, it can be used in the formulation of platelet extracellular vesicles, or in the form of lyophilized platelets. And we know that the problem with the conventional bone grafts is they don't have the signaling mechanisms. Okay, they're more of a scaffold. They don't have the cells, and they don't have the bioactive molecules. So this platelet concentrates, when used in these formulations as PEVs, okay, they will be able to provide the biological stimulus that is required for functional regeneration. So when we take the immune response along with biomaterial, most of the times when we use the biomaterial, what happens is initially there is a small window where we have this macrophage polarization. Initially, when we place a bone graft inside a defect, what happens is the initial interaction between the bone graft and the cells. Okay, that is the rate limiting step will be the interaction that happens between the fibrin fibronetic network that forms between the bone defect and the bone graft and the cellular mechanism which get triggered. So irrespective of whatever bone graft we are going to use in the defect, it will be identified as a foreign body. Okay, and you will have this pro-inflammatory cytokines that are pro-inflammatory, M1 macrophages which are upregulated, which are pro-inflammatory, which are detrimental to healing. So when we use platelet concentrates to modulate this along with bone grafts, this M1 polarization goes down and macrophages with M2 polarization, which are tissue resolution macrophages, which facilitate regeneration, are going to be upregulated, thereby facilitating true periodontal regeneration. So the idea is to use this platelet concentrates along with whichever matrix, bone grafts, or whichever you're going to use, so that platelets provide the growth factors in the formulations which I mentioned, platelet extracellular vesicles or lyophilized platelet concentrates. Okay, along with the bone grafts are going to give the BMPs. Okay, so they help in optimal regeneration as well as remodeling. So initial part of it is totally outdated now, the literature, especially because of the protocol and not appropriate usage of this platelet concentrates in the correct formulation. The way forward is using lyophilized platelet concentrates and using it along with other biomaterials which I just mentioned, using along with drugs for antagonism and synergism, and also using it along with stem cells. So to conclude, based on literature review on my own publications in platelet concentration, platelet concentrates are intangible in the formulations which we have been using for the past 20 to 30 years for periodontal regeneration. If at all, they are only facilitating healing and some amount of immunomodulatory effect due to lack of conclusive evidence supporting their effectiveness. As the 2014 paper by Chokran and Miran, they clearly state that the protocols which have been followed in all the publications or most of the publications are void. Second is the proteomic analysis revealed immunomodulatory and antimicrobial markers, no regenerative markers. The third important point is invalid evidences from scientific publication, as I mentioned, due to technical considerations and lack of clarity regarding which formulation of platelet concentrate should be used in which clinical condition. Okay. And the new strategy for personalized tissue regeneration, where platelet concentrate extract can bridge the gap between scaffolds and cell biology in the form of lyophilized platelet concentrates and platelet extravascular vesicles. These are the way to go. So where we need to work a lot and which will give a clearer picture. So these are my references for this presentation. With this, I end my presentation. I thank Gautami ma'am for giving this wonderful opportunity to share my views and also share my papers along with all of you. And I also thank Ashita ma'am for the discussion and inputs which she gave. Thank you.
Thank you, sir, for that wonderful presentation of yours, and thank you, ma'am. Now over to the moderators to moderate the session, Dr. Varsha ma'am and Srihari sir.
Yes, good afternoon once again, all of you. Good morning, rather, till there is time. So, Dr. Gautami and Dr. Muthukumar, excellent presentations. You have really brought in insights in various aspects, ruled out whatever doubts we had, and I'm sure even the students have gained a lot of knowledge. Dr. Gautami has given ample of evidences related to articles which have been published till date, and Dr. Muthukumar has given the insights of the preparations, and it was an excellent one, sir. Hats off to both of you, and we are truly indebted and privileged to be part of this session today. We had two questions in this today's scene. For Dr. Gautami, the question was whether PRF was, PRF, What was the question? I had just written somewhere.
Ma'am, those two questions were answered, ma'am, in the chat box.
They were answered in the chat box. Okay. Is albumin PRF and ePRF same?
Yes, ma'am.
And,
Those questions were answered already.
yeah, and for Dr. Muthukumar, again the same related to same that what is the difference between PRP and IPRF?
The CPRF is considered to be optimal liquid formulation. As I told you,
Yeah, that is what. Yeah, it is. I think
it does 2000 RCF, 2000 RCF for 8 minutes. We valid, and I think I shared my paper also. So it has growth factors and optimal concentration. IPRF, on the other hand, it's 700 RPM or 20 G force for 8 minutes. So not only the G force and RCF, as I told, you have to see, irrespective of whichever centrifuge you use, you calculate based on the formula which was mentioned, and then you check the release profile whether it's optimal before you do a clinical.
Okay. So I move on to my co-moderator, Dr. Sri Hari. Sir, you want to
Yes,
have
ma'am.
any thoughts? Yeah.
Yeah, it was an excellent talk by both of them, madam and sir. It was very eye-opening for particularly for PGs. What they do, what as Muthukumar sir was telling, immediately we have to place it back. Any PRF material, what they do, they take it, keep it in the near the patient and do later. It has to be done before a minute. And one more thing is important stress is that on RCR. RCF factor is very important as we are not having any standardized anything like a centrifuge we are using. So we have to think of RCF factor that is very important for converting. This will be, I think, an eye opener for all PGs who will be knowing, and even for us also. We are also learning many things from this. It's a good talk from both of them. As Madam has given good evidence, and even from Muthukumar sir also has given a good things where we have to standardize our things so that we can have a better thing over things. Thank you, both of them. It's an excellent talk with both of them.
Sir, actually, regarding the preparation protocols and the machines and the tubes, which Muthu sir was telling, in the recent article by Miron in the year 2025 in the JPR, Journal of Periodontal Research, that which I was discussing on the 30 years of autologous platelet concentrates, they have clearly mentioned that unfortunately many earlier publications on PRF and PRP protocols inaccurately reused the RPM based settings on centrifuges with dissimilar rotor sizes, thereby resulting in inconsistent and often unreliable results. And numerous even influential publications from over 2 decades ago failed to report this RCF or G-force values together. So now in this article they have clearly mentioned that even though we have been addressing these discrepancies, in 2019 a consensus was reached regarding emphasizing the importance of accurately reporting the RCF and the G-force, which sir was very clearly mentioning in his presentation. So as to improve the methodological stability and standardization, thereby improving the future reliability of scientific publications. So as per this new article, even those problems were addressed and care is being taken to standardize the publications, thereby standardizing the G-force and
it is from the academic point of view. As a clinician, we have to think about all these centrifuges, madam. We use randomly what type of centrifuge. Many institutions doesn't have a standardized centrifuge. Some will use interspin, some will use APRF. Like that, for standardization, it will be useful for all of us. Particularly like 33-degree angle and horizontal capillaries. What Muthukumar sir was talking about, that horizontal, many studies are thinking of that horizontal standardization, vertical things about how the PRF is going on. It's a good talk, madam. It's a good thing, and we will also go to into. Sure. Thank you.
Any inputs from Nandakumar sir and TK Paul sir on the topic? Because you have been seeing PRF since 2000, so you had a long journey together. What is your intake? Sir, please unmute, sir.
Hello.
Yes,
Hello.
sir. Now
Can you hear?
Yes, sir. Nandakumar sir, we can hear you.
Yeah. So I just wanted to know, the lot of literature has been done, research work, but clinical application is more important. So especially in the cases of periodontal conditions, because as you rightly said, the core structures has to be formed. When you put in the PRF, the molecules, that is signaling molecules is different. So it has to act in the specific site. And it is in a we have to get the tissues regenerated, appropriated, and it's very difficult to get an environment in a periodontal disease condition. So that's a very important thing. That's why we are not getting adequate results, clinical results. When you say that we get a lot of regeneration, but we are not able to get clinically tangible result, we are not able to get it. That's the most important thing. What do you say about that?
I totally agree. Sir, please unmute, sir. TK Paul, sir. Unmute and write. Sir, Paul, sir, please unmute yourself.
No, I mean, I have to move now. Give me permission to leave now.
Yes, sir. Yes, sir.
Okay. And thank you very much for all the discussions, all the
Any
speakers.
sir, any conclusive remarks from your side?
No, it's all that I'm enjoying. I've been enjoying through the whole session. Thank you. Thank you very much.
Okay, sir. Thank you.
Yes. Good morning, sir. Muthukumar sir, I just want to ask from you. So, as the protocol of PRF preparations has changed, so it is changed due to get the maximum potential for regeneration. So, few of protocols have changed by changing the centrifugation method. So, from vertical to horizontal, and also they are changing the protocol, like increasing the temperature. The denaturation is happening, and they want to extend the time of release of growth factors. So, like this, as the time test tubes, even the test tubes are being changed from silica to titanium reinforced platelet rich fiber. So, by changing all these protocols, can we maximize the regeneration potential?
So thank you for the question, sir. As I was mentioning in the last segment of my presentation, irrespective of all the protocols formed, if you're going to use APRF or for that matter IPRF or CPRF, it cannot be extrapolated in a clinical situation. So as I was telling, there is going to be a lot of enzymatic interactions in vivo. And if at all it's going to work only in the initial phase, hemostatic phase of regeneration. It will facilitate that. Okay, maybe it has some immunomodulatory effects because leukocytes are there. If it has to be workable in the regenerative phase, we have to go for lyophilized platelet concentrates, or we will have to go for platelet extracellular vesicles. Only then we can tell actually it's helpful. So far, it's helpful in healing and it's helpful in immunomodulating with some amount of antimicrobial property. It's a very big word to tell that platelet concentrates help in regeneration. So that is the current consensus given by Kobayashi, Miran, who are the people involved, Don and First, etc. So whatever we have been doing is some amount of immune modulation and some amount of healing felicitation. To take that point to clinical scenario, what like Sri Hari sir was telling, it's only being used mostly in Asian countries like India and China because of its economic viability. The moment you're going to get a horizontal centrifuge with all the tubes, most of them will not be working to get optimal growth factors and to have optimal results. That is the truth. That is the truth. For example, if you're going to go for lyophilized platelet concentrates, or you're going to separate platelet extracellular vesicles, it's going to be expensive. That's going to be the next 20 to 30 years. Lyophilized platelet concentrates and platelet extracellular vesicles. By the time we procure the equipments, they will go into the next phase. Okay, they will go to the next level of platelet concentrates. That's what is happening in Asian scenario. Now, what they have done 20, 30 years back, we are doing and publishing. So we can optimize to an extent, but it will be only immunomodulatory and facilitation of healing, not true regeneration. For that, you need sustained release over a 4-week or 8-week period, and optimal concentration in various parts of the cell cycle, wherein they trigger the appropriate signaling mechanism to bring in the appropriate cell lineage to facilitate regeneration, which is a big thing.
One more doubt, sir. In case of extended PRF, is it that actually normal PRFs and all it will release growth factors up to 2 to
Yes,
3?
sir, that is a misconception, sir. That albumin PRF and extended PRF, albumin PRF and extended PRF, the difference is in albumin PRF, just we heat and no, we clot it. When we do that, the fibrin architecture goes off. The very essence of using PRF is because it is considered as a natural tissue engineering construct with a scaffold, cell, and signaling mechanism. The scaffold part of it is gone when it becomes thick with albumin PRF, wherein the release profile is totally impacted or nil and void. Second thing is to activate that extended PRF was given by Miron, where they prepared CPRF from the same individual from which this albumin PRF was prepared, and with 2 female lower lock syringes, they activated that with CPRF to have release profile. But the problem is when this is done, it will not integrate with the fibrin network because fibrin network itself is not there when we are going to heat it and make it thick albumin PRF. So the question of extended release goes off. As long as it is there, okay, for initial few hours or few days, release profile will be there. So in vivo, a lot of work has to be done as much as in vitro. Well, because it's coming out new and it gives some amount of density, it can be used as fillers, especially in plastic surgery, and it can be used as a barrier. Okay, not a biological barrier, as a barrier membrane, as a membrane, not as such for regeneration.
But that it's given that from 2 to 3 weeks, 4 to 6 months, they've extended when they use.
That in vivo as well as in vitro, but the extended thing has not been proved. The thing is, when it is heated, the disulfide bonds which are present in the fibrin architecture are gone, which has been proved. So the growth factors are not going to entangle in that for it to have a sustained release. So whatever initially the CPRF, which is concentrated along with albumin PRF, which is called as the extended PRF, that will remain because it's not resorbing over a period of time. As a membrane over it, some amount of activity will happen because it is a natural material other than apart from being a foreign body. So that way there can be some amount of release, but definitely not the optimal amount.
So just I wanted to know what are those hydrophobic tubes, sir? We always see the silica tubes with red cap, but I've read somewhere about hydrophobic tubes with blue cap.
These hydrophobic tubes are nothing but coated tubes, which are cheaper, which are available in all the labs. Like I say, when we prepare the PRF clot, it is going to activate the intrinsic clotting mechanism. Okay, the rate limiting step is conversion of factor 12 to 12A, which will not happen when there is a coated tube because mostly it will have silica. Okay, and they are not active tubes. When there is a pure glass, it actually has some amount of activity without any chemical added onto it. This conversion of factor 12 to 12A happens and the actual clot forms. So that's what they mean by active tube and inactive tube. You should have pure tube which is made up of glass, top quality glass, which Chokran and Myran uses, which is really expensive and which is not affordable for us in colleges or practice. So most of the time, what we get is coated tubes which they use in labs, which are inactive tubes.
What about your stand and TPRF tubes?
So TPRF, I showed our own study, sir, where the fibrin architecture as well as the tensile strength, everything is high. But when it comes to release profile, what we found was we did PDGF AA release profile with titanium PRF. Initial time point up to 6 to 24 hours, it was optimal. As from day 2 to day 7, it gradually tapered, which showed that the release profile is not optimal. But the fibrin structure was intact. We saw in different magnification at ultra microscopic level, from 10x to 6000x. At different time points when we saw this fibrin, it maintained the integrity when we used TPRF. And when we did an elemental analysis with TPRF, there was no silica particles which are considered to be toxic to the osteoblast as well as to the periosteal cells. So they had titanium particles which facilitated bone healing. That was the only advantage compared to the conventional. But apart from that, release of growth factors, no. Compared to your APRF plus, it is much lesser. Okay, and structurally it is more stronger.
Sir, in the literature, it's been even saying that even the PRF which is prepared through TPRF tube is osteoinductive.
Yeah, that's because, like I said, during centrifugation, titanium particles, some amount will get entangled. So based on that, they say it promotes, and the quantity or amount needed has not been extrapolated in vitro as well as in vivo. In elemental analysis, it shows that when we do elemental analysis after centrifugation with the titanium tube, it has some amount of particles of titanium, which is hypothesized to facilitate osteoblasts or proliferation of osteoblasts. That again was the in vitro.
So one more question from my side. Sir,
Yeah.
do we incorporate any nanoparticles into the PR? Is that helpful?
Sir, that is a work in progress. Sir. Like I said, you have to prepare these new formulations like lyophilized PRF or platelet extracellular vesicles, and that can be made into nanoparticles and coated to your bone grafts or membranes, which is a very big level of work which we are working upon. We'll get a publication sometime near future.
Thank you very much, sir. Sir, one question for all the three resource persons, Shida ma'am, Gautami ma'am, and Kumar sir. Sir, see, when we have like a PRF which is prepared from healthy and periodontitis patients, and periodontitis patients with systemically unhealthy patients. So, do we have an effect on the structural and mechanical properties of PRF when prepared from healthy?
Sir, I answered this question during the presentation itself, sir. So, irrespective of whether the patient is systemically healthy or diseased, the release profile and growth factor concentrates are going to differ. It's patient specific. That's why you will have to select individuals who have good release profile, optimal platelet concentrates, and get allogenic platelet concentrates and lyophilize them. So, even you can use that on anyone. You can use that on any individual. You prepare and keep, lyophilize and keep. You can use in a diseased patient, provided the systemic disease is controlled, it will be effective for them. But the release profile of growth factors will be same, whether you use it on a healthy individual or a diseased individual. Okay, allogenic platelet concentrates is the future. It is not going to be prepared from patient's own blood. Like how you do blood transfusions, for example.
I've seen this point during your presentation only, sir, but I just have a doubt on why
Yes,
all.
I think I clarified. Anything else? I'm ready.
Actually, whenever we have like patients with intrabony defects, always we try to use PRF. So when already the patient is with periodontal disease, so obviously the PRF membrane, what we prepared from that will be of less integrity also. Still, they are using it into the intrabony defects, into the Caucasian defects.
Sir, that's what, sir. They will first is they don't have mechanical stability, sir. They cannot be used. Which formulation to be used for intrabony defects for it to have optimal effect is questionable. We cannot prepare a APRF or a TPRF and place it inside just like that. So, which formulation you are going to use? This Chakran, Micron, and Miran, they say that they will have to be polymerized and cut into pieces and then used. That is one of the way of using. But as I told, in intrabony defects, its effect is questionable because of its mechanical properties. And if at all, it will help only in bone formation, not pedial regeneration. It has limited impact on that. I told you the reason in my very first slide. So it's a very difficult balance to maintain it in a hypomineralized or non-mineralized PDM. And to regenerate it is, I think it can be done only by God. So second part of your question is membrane. Membrane will collapse if it is used as a membrane, as a GBR membrane, because it doesn't have enough mechanical properties to withstand the forces even when you're going to close the flap. And the very idea of space making, which is the core of using membrane, is going to be gone there itself. You don't have the space for the clot to form and regenerate. So neither it can be used as a membrane, nor it can be used. Like I said, It will help in immunomodulation, and it has some antibacterial effect, and it helps in macrophage polarization, thereby facilitating regeneration. Indirect effect, no, which we cannot tell how much impact it has on macrophage polarization, how much of antimicrobial or how much of immunomodulatory. So that is a big question. But as it is, it doesn't have any regenerative potential.
That's what, sir. The article by Richard on guided bone regeneration, they have clearly mentioned that utilizing PRF membrane, it should be applied only as an adjunct to collagen barrier membranes. That too, it should be directly.
Exactly. That is again to reduce the foreign body reaction.
Primary scaffold.
Yeah. When we use the PRF membrane along with the regular membrane, what happens is the regular membrane is identified as a foreign body, and you will have M1 macrophages which are upregulated, which are tissue inflammatory or pro-inflammatory. When it is used along with this PRF membrane, with your conventional membrane, what happens is this M1 macrophage polarization will be down-regulated, or it will be minimal, because the foreign body reaction goes down. Okay, so that it facilitates earlier regeneration by bringing in M2 macrophage polarization. That's why they have quoted as has to be used along with it. So any other thing, anything else? I think you can tell Gautami ma'am. We can answer by mail also.
Sir, and there were two questions in the YouTube. Was horizontal PRF developed by Miron?
Yes. Obviously, it was developed only by Miron.
Yes, sir. But he did it along with a set of colleagues in China.
Yes, ma'am. But he has been only credited. Miran and has been credited with the protocol for horizontal centrifuge.
Yes, sir. And one more regarding the protocol for albumin PRF, which I think it will be around some 2,200 to 2,700 RPM with a speed force of 700 grams for 8 minutes. That's what given in the literature.
This is for albumin PRF, ma'am. Ma'am, albumin PRF can be produced from any of the protocol. You can use a APRF protocol, or LPRF protocol, irrespective of RPM, RCF time. You heat it, you will get albumin PRF. So there is no fixed protocol. Okay, and then you have to activate it with any of the liquid formulations. That is again the current concept given by Chopra. They say CPRF is used to activate. Like I already answered, you lose the fibrin architecture and then you try to integrate growth factors. The tissue engineering construct is destroyed there itself.
So what's the temperature you suggested for the heating process?
Sir, that again, sir, like PRF machines, we cannot heat on our own and cool on our own. There is a Chokran thing, bioheat, biocool device, which we have to procure and then do it. They have the fixed settings for that. Okay, so they are very specific. So we cannot, again, the same mistake we cannot do. Like they use this amount of temperature. We will also use in our setting. We will use with our machine. So I'm not quoting the temperature and time. So you have to get a bioheat machine and a biocool machine, which is being which was advocated and patented by Chokran. So that will be the ideal thing to do. Get an optimal work out of.
Sir, in the literature by Miron, it's given that accelerating and denaturation at body temperature 37 degrees. It usually in an incubator it accelerates the clotting and increases the density of the matrix.
Yes, ma'am. There are specifications for that incubator, whatever we are going to use.
Yes, sir.
And the patented bioheat machine, which is available from Chokran school, it will be the optimal thing. Otherwise, to control the temperature as well as the time setting based on our preparation, it's going to be difficult. So using the appropriate protocol for preparation and the bioheat and biocool machine, which is available in the market, that we will have to use and work on albumin PRF if at all we are going to work on that.
And any questions from the attendees?
Morning, sir. This is Dr. Shrutima, sir.
Yes,
I have a question.
As correctly said, lyophilus PRF has been in recently in most of the articles, and it's proven to be very effective. But how practical is it to use a lyophilus PRF? Because frozen PRF is easy for preparation, chain-side preparation. But lyophilus PRF, how to procure the equipment and how to use it, sir? Is it really practically applicable for
It's practically, yes, ma'am. Yes, ma'am. It's practically applicable, but again, we need standard equipments. That is the issue. We cannot. There are a lot of lyophilizers which are available in many labs, but they will not give optimal results. So lyophilizer, there is a specification for lyophilized platelet. This is not the Chokran's group which is working on it. It's totally a different group. So we need still now they have not come out with the proper specification. So we are still waiting to have it's available in most of the blood banks and other places, some of the labs which work on platelet concentrates. But which is the optimal setting? That is a question for freeze drying. That is a question. Based on the conventional protocol, if we do like how you rightly pointed out, it will be subjected to enzymatic digestion, etc. But if the proper protocol is followed, and it is again not based on fibrin matrix. So if it is lyophilized and it is powdered, it's only the growth factor concentrates which we use. I mean, in a powdered form, which is it's something like how we use recombinant growth factors. So they are readily available in that concentration, but you need a scaffold for that. In this case, PRF is not going to act as a scaffold. So the question of the fibrin integration will not come in this.
Sir, and again in lyophilized, I think you should really freeze them minus 80 degrees C for 30 minutes and then freeze dry for minus 54 degrees C.
Yes, ma'am. It's a bigger technical.
Machine will give both the options of minus 80 and minus 54.
Yes, ma'am. Yes, ma'am. It's a cyclic thing which has to be repeated to get the optimal results. And like I said, we don't have standardized equipments. We are also trying in whatever is available, but the release profile and other things are not standardized. So unless from the school which is working on that comes out with a protocol like Chokran and Myron, we will not be able to simulate it. So we can work on it and find out the optimal thing, but I don't know how it will go. It's going to take a lot of time.
Have you tried this allogenic platelets, sir?
No, that's what initially experimental work has been done. So we are not able to standardize. So I'll share once we are able to standardize, and I'll keep updated.
Okay, thank you.
Thank you. Thank you.
Thank you. I think we can end the program. And before ending, Vandana ma'am wants to share these particular videos. And that comes to an end of the 8th edition of Perio Akshaya. Thank you so much, ma'am, Ashita ma'am, Muthu Kumar sir, for making presentations as interesting as ever in spite of your very busy schedules. And thank you, Varsha ma'am and Srihari sir, for being there throughout the session and moderating in a very fantastic way. Thank you so much. And I thank Dr. Nandakumar sir, TK Paul sir, Bela ma'am, and all the participants on the platform for giving us one more opportunity to host this session in a very interactive way.
No, I think thank you, Gautam, and thank you, Muthu. I think you've truly answered all the basic questions. I think in fact, it was a kind of enlightening session for me where you talked about lipophilized and you talked about allogenic platelet concentrates, which was something very new. And even that extended vesicles, what you were talking, I did read in the literature, there was no clarity on this. So I think these are things, which we had clarity. And as you very rightly said, that fundamental biologics is something which we still have to work on. That means we still have a lot of preclinical studies to be done. And I think compliments to you, Gautami. I think you've been doing a wonderful work on platelet concentrates. I'm seeing even today you've been doing it. Probably, I think we should have some kind of a collaborative research where, probably we can, the output would be better. And one point, I think what Dr. Muthu was very rightly said, I think Gautami, in your bibliometric analysis, where you very rightly said, in the whatever the studies were in the developing countries, which Muthu rightly said is, why has these platelet concentrations become so popular is because of the cost effective. Because of the financial constraint, I think they are here to stay. Even though, like Dr. Muthu said, that true periodontal regeneration we may not be able to achieve, but definitely whatever regeneration, what we are getting is, I think that is fair enough clinically. With Dr. Nandakumar said it, I think there's a clinical versus we are talking about what we are talking about the preclinical data. So I think now we have to balance together. Until then, as Dr. Muthu very rightly said, the next 30 years we may have EPRF coming. But I think, Muthu, I'm very confident that today in India, I think it is going to come less than 30 years, we will be using it. So that's all from me. Thank you so much. I think it was a truly enlightening discussions what we had. Thank you, Gautami. Thank you, Varsha. Thank you, Srihari. And thank you, the entire team of Vishnu Dental College. It was really, I really enjoyed being a part of this program. Thank you.
Thank you so much, ma'am. Thank you so much, ma'am.
I'd also like to thank Gautami ma'am once again for this wonderful opportunity.
No, it's a pleasure, sir. Both of us have done the same thing in Savita, but then you were very aggressive. I thought, but then
if it is live, I would have been more aggressive.
Yes. No, sir, you really cleared part all my evidences that day. So I thought I was really, this Miron's article and the bibliometric analysis thought they will definitely save me today, because that day when I was presenting, all these were not there. It's almost a year ago.
So thank all the respected seniors for sharing your views and for giving the audience here, especially Ashita ma'am, Varsha ma'am, Hari sir, for your time and participating in this. Thank you so much.
Thank you, sir. Thank you, Gautam. Thank you,
Vishnu
Dental College.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you, Dr. Anupa Shetty. Anupa. Thank you all once again.